Okay, I was just worried we wouldn't be able to hear folks.
Cool.
No, that people the lights are set in front of the monitor. But well, I don't know how to say his last name.
Nice to meet you. Nice to meet you too.
Is she ready for us? Hi, everybody. We're going to get started in just a minute. All right. Everyone take your seat. Get ready for our fun-filled afternoon. I want to thank you all for taking the time out of the day to join us here today. My name is Jennifer Claxton. I'm the Director of the Care Services at the Golden West Chapter, and I have the privilege of overseeing the amazing team of care managers that work with you in your homes every day. I think you're going to find many of them are here today. If you're looking for your care manager, just ask around. They're probably here. Welcome to our annual Ask the Experts meeting titled Help for Today and Hope for Tomorrow. We hope you gain many tools for living with ALS and an insight into research that is going on in the world of ALS today. I also want to introduce you to our new Vice President of Care Services, Audra Hines. Audra has worked with the National Multiple Sclerosis Society for 15 years, overseeing client service programs and individuals with MS and their families throughout the Southern California and Nevada area. She has experience partnering with clinics and healthcare providers to ensure access to specialty care in neurology, mental health for people living with MS. Oh, excuse me, I'm in the ALS world. In the last 2 years, Audra worked with Partners in Care Foundation, overseeing health plan contracts and a network of community-based organizations that provide in-home assessments, care plans, and help for health plan members. So we're going to kick this off first with Dr. Abby. Most of you know her, those of you that attend Cedars. Come on up, Dr. Abby. How do I move the slides? Just trying to figure out how to move the slides here. So thank you everyone for coming. Good afternoon, and I'm Dr. Abby. I'm with the ALS clinic here at Cedars Sinai. I've been here for more than 10 years, and this is one of my clinics that we do every Wednesday throughout the year. And I wanted to give a brief overview of how the ALS multidisciplinary clinic works here at Cedars and in most other places, and open the stage for the rest of the talks that talks about specific disciplines and clinical trials and so on. So as you can see, it's really a multidisciplinary approach. It takes a village to run an ALS clinic, and as you all know, it's a very complex disease and takes many disciplines. So when the patients come to our clinic, it's first the neurologist evaluates, and first we want to confirm the diagnosis, and of course the nurses play a vital role. And we have some helpers, we have social worker to help with the insurance and other needs for the patients if needed. There is a clinical trial or research coordinator who meets with the patients if they're interested in participating in trials, and even if not, to give them information. And pulmonologist plays a very critical role. I know he's not available today, but he's in our ALS clinic every week, seeing our new patients and follow-up patients. And he assists along with the respiratory therapist to provide them with the non-invasive ventilation, the BiPAP and suction device and all that. And we have an alternative communication device specialist for somebody who has speech problems to evaluate then and there, and of course occupational therapist. And we work closely with the GI department here at Cedars
When we need the gastrostomy tube, when the time comes, then the patients are already plugged in the system and it's done electively. And we have a speech pathologist who evaluates for speech and swallow function, and we have wheelchair specialist vendors. Some of them are out here. Feel free to say hi and talk to them. So they can address some of the needs with the power wheelchair and so on in the clinic itself. And we have physical therapists and ALS Association case manager and registered dietitian who follows patient at every visit. I forgot on purpose one person who I could not fit in the circle, but she's the most important, Tammy, who's the ALS coordinator in our clinic. So she's the center of this wheel. Without her, none of these will be able to move at all. So she plays a very vital role. So our ALS clinic follows pretty much the guidelines that was set forth back in 2009 by Robert Miller and group up in Northern California, who came with the practice parameter guidelines, and clearly studies have shown again and again that it improves clearly the survival and quality of life for the ALS patients. So all ALS patients should be in any one of the multidisciplinary care. It doesn't mean you have to be at Cedars, UCLA, UC Irvine. So there are many multidisciplinary centers, but we want them to be plugged in one of those clinics. So moving on to treatment, I know Dr. Burford, who's the speaker after me, is going to talk more about the treatment, so I'm going to skip the slide. So just to say two lines, we have very limited FDA-approved treatment as of now for ALS. As you all know, one of them is riluzole, works on glutamate, but it's modest efficacy, not very good. And then came edaravone. There was a lot of buzz in the last couple of years, otherwise called Radicava, based on the Japanese trial, that it slows by about 30%, slowing the rate of decline in the ALS-FRS compared to placebo. Still not good enough, so we still need, obviously, better treatments that will, change the disease course or even arrest it. So in the meantime, there are a lot of things that can be done in the clinic in terms of managing the day-to-day symptoms. So we use antidepressants commonly with somebody who has depression. It could be mild or moderate or severe. It can happen at any stages in the disease. So some of the common drugs used are tricyclics and serotonin reuptake inhibitors, and we have evaluation with our neuropsychologist in the clinic. And emotional lability, it's otherwise called pseudobulbar affect. It's commonly seen in bulbar onset patients, and there are effective medications. In the past, we used to do the tricyclics and SSRI, but now we specifically have the new Dexta, which is the combination of dextromethorphan and quinidine. And recently, studies have also shown that it also may help with the speech and swallowing function in addition to help with the emotional lability. And there was a Niels trial that was a randomized study conducted in 2017 by Dr. Richard Smith group, who validated this. And fatigue is again very common. It's multifactorial part of the disease itself. Sometimes the medication, riluzole and Radicava, can itself cause fatigue, and those are managed as well if needed with medications. So treatment of pain, this is often underestimated, even though we kind of say it's a painless, progression of weakness. There is a lot of times everybody undergoes, experiences at different stages, some sort of pain from any degree, and it's multifactorial. As you can see, it's from immobility, spasticity itself, or weakness, positioning issues. There are different common scenarios, and we use muscle relaxants for those, including baclofen or tizanidine, which is also called Flexeril. And again, pain is treated adequately as needed with variety of medications, from gabapentin to pregabalin or Lyrica, tricyclics like amitriptyline, or non-steroidals like simple, high-dose naproxen as needed. And even narcotic pain medications have to be used when the above medications fail, or in combination of this, depending on how much the patient tolerates. And muscle cramps are very common, especially earlier on in the disease, and as well as later on with spasticity. And again, gabapentin and magnesium are some of the useful medications, in addition to stretching and other modalities as well. So sialuria is the excess production or the drooling of saliva, so-called, and it can be a big nuisance socially, and also it can increase secretions and cause some choking, so we want to adequately manage that. If it's very mild, we kind of watch, and if it interferes with the patient's activities of daily living, then definitely it's worth treating. And there are oral medications, glycopyrrolate or Robinol. It's used even through G-tube. You can give the medication, and it decreases the saliva production. Sometimes it can cause more dryness, so we need to kind of figure out the optimum dosage. It can be given 2-3 times a day. And there is also a transdermal patch. If somebody cannot tolerate this, then, or it's not effective, then we go to the patch, like scopolamine is one of them. And the patch is changed like every 3 days. There is also a topical eye drop, which we use it orally for the mouth. You can do 1 or 2 drops as needed, up to 2 to 3 times a day safely. Sometimes beta blockers like propranolol are used for thick mucus production, along with suctioning and cough assist to effectively get rid of the secretions. So if all of these fail, the patch and the oral drugs, if they are not effective or they have side effects, then the next step is botulinum toxin injection. That's very effective. There are 2 types, botulinum toxin type A and B. Both are good, both are equally effective. And the injection is given into the parotid gland. And there are many studies. The recent article was published in JAMA by another group in January of this year, again confirming that botulinum is very safe and it's very effective. And this is a simple graph showing, it's a patient questionnaire, the clinical global impression of change. They found more than 50% reduction in the drooling of saliva, self-reported by patients. You can see the orange and the blue is the treatment arm, 2 different doses, 2,500 and 3,500 units compared to the top, the black one, which is the placebo. But the only thing is, it has to be a repeated injection. By 12 weeks, you start seeing the curve goes to the placebo. The effect of the Botox wears off after 12 weeks. So you have to have repeated injections, so every 3 months approximately. So again, in multidisciplinary management involves, medication management plus involvement of other disciplines, PT and OT. And the goal of therapy is again to maximize function and to improve the quality of life, prevention of falls, prevention of contractures, and also help with assistive devices and transfers and provide patient and caregiver education. And I think, we have more detailed sessions on PT and OT in a few minutes. And every clinic visit, again, the swallowing function is assessed by our speech-language pathologist. And we want to do the video swallow study if there is any question in swallowing, and we advocate early placement of the G-tube rather than waiting till the end, and then it becomes a high-risk procedure. We want to avoid ER visits so we can plan electively and do it. So some of the things when we talk to patients about G-tube is when they have moderate to severe swallowing problem. I would say more moderate rather than severe. We don't want to wait till that. And when there is more than 10 pounds weight loss, or it takes 2 hours for them to complete a meal, or worsening of the respiratory status. So these are all the indicators to intervene with the G-tube. And we work with our GI department closely. And likewise, the speech therapist, evaluates patients for the communication device when their speech is slurred. And respiratory failure is one of the most dreaded complications with ALS, as we all know, as it affects the diaphragm and other muscles throughout, with the progression of the disease. So we check the forced vital capacity and NIF every 3 months, and if they are symptomatic, even sooner. So in general, when the forced vital capacity drops less than 50%, then you give them the non-invasive ventilation, which is the BiPAP or Trilogy. And even if it's not 50, but let's say it's like 55, 60, and the patient is symptomatic, already they say that they can't lie down in the night, then that justifies using this earlier. So we don't want to wait. We want to intervene early and support the breathing. And invasive ventilation is considered when the forced vital capacity drops very low, but we have a lot of patients who are even at that well managed with maximum pressure support on Trilogy. The newer machines are very well sophisticated with non-invasive ventilation, so we rarely have to go for that. And treating any underlying infection, pneumonia, sometimes happens frequently as the disease progresses and the muscles get weaker. So if all of these can be adequately diagnosed and treated earlier on. And anxiety is very common, comes along with the respiratory distress, so we use short-acting benzodiazepine like Xanax, so then they can tolerate the mask better with the non-invasive ventilation. So overall, multidisciplinary clinic, it clearly improves patient access and patient care directly, and it's cost-effective, prevents unnecessary hospital last-minute ER admissions, and it gives an opportunity for patients to participate in clinical trials, and also provides a lot of education so they feel they can handle this tough disease. So in conclusion, we need to provide more access, more multidisciplinary clinics are needed, and improve the number of trials in a hope to find cure for this disease soon, and work with different organizations, as said here, to achieve these goals together. All right, that's my talk. Thank you very much. So I think after a couple of more talks, we take questions at the end for 10 minutes. So now I'm going to introduce the next speaker, who is Dr. Matthew Burford. He is one of our neurologists with the ALS clinic. He's a neuromuscular expert. He did his training from WashU. He is the assistant professor of neurology and pathology. He's been with us since 2017, and he's very active with a lot of clinical trials, and it's a great pleasure to work with him, and patients love him. So we are happy to have you, Matt, and he will talk about the current treatment and the clinical trials on ALS.
Okay. Well, welcome everybody to Cedars. Very happy to see a lot of familiar faces and a lot of new ones here. And thank you so much to the ALS Association for allowing us to be a part of this. So I am going to talk to you guys about treatments. Where are we now with ALS treatments? And I'm happy to say that there's far too much to fit into a 15-minute talk here, but we're going to do a bit of a whirlwind tour and hopefully spark a little bit of your interest to continue the conversation, because ultimately that's how we really move things forward. So hopefully I can make this thing work. That's that. Oh, there we go. A little bit of a summary of the talk, just to kind of get us started. So I'm going to start with the treatments that we have already available that Dr. Abby alluded to already. And then we're going to move into why the heck do we only have those treatments available right now? And what are some of the things coming down the pike? So let's get started. I think we're all familiar with riluzole, one of our old friends in the treatment of ALS. It was one of the first medications that was studied and the first one approved by the FDA in 1995. It works by blocking some of the excitatory neurotransmitters and hopefully helps in kind of maintaining the health of some of the motor neurons. It has some modest benefit on survival. And when it was first approved, it really sparked everybody's interest. We were kind of moving in the right path, and we were getting ready to kind of really hit that renaissance of treatments in motor neuron disease. And then 22 years later, it was still the only medication that was approved. But luckily, soon thereafter, in 2017, we did get approval of edaravone, or Radicava, which is the infusion medication, which you might know of, which works by lowering some of the oxidative stress that happens within the cells and improves the health of the motor neurons in general. Again, a bit of a modest benefit as far as reducing the progression of disease, but still something new. And this isn't even the only part of the story on both of these, because still now we're still getting a few new formulations of these medications. So Tiglatic was approved by the FDA in 2018. It's an oral suspension to kind of help with folks who have a little bit more difficulty with swallowing. And then even more recently, another form of riluzole, an oral dissolving film, which can be placed under the tongue and has equal efficacy and is a little bit easier to administer. Now, interestingly enough, one of the things that goes on with radicava is as an infusion medication, it can be a little bit more challenging to set up and get going. So there is a new trial going on right now looking at an oral form of this medication to see if it has equal efficacy. And hopefully that'll increase people's availability of this medication. Now, the question though comes up, why did it take 22 years to get even a second medication approved? And this is a tough discussion, but I like this picture for a couple of reasons. The first of which is because it's a really confusing looking picture. And so all of these boxes here indicate things that contribute to the disease process. And so the difficulty with designing therapeutics is, well, what do you target? Which one? And if you're going to pick one, which is the right one? And it's hard to make that decision, and it's hard to choose and change your path if you need to. So just as an illustration, riluzole affects this area. Edaravone kind of attacks this, but we still have all these other things going on. And so how do we actually get at those in order to make sure that we can move forward in getting the right treatments and the best treatments for this disease? And one of the ways is to get down to the root cause. If we can figure out the single thing that leads to all of these other boxes popping up, well, that may give us the most effective treatments. One of the places that we can very easily do that is when we have patients that have a genetic form of ALS, because we know that it's that mutation that ultimately is leading to all of the changes that we're seeing. And that's led to a lot of very interesting forms of both research and now increasingly treatments. So most recently, people have been targeting the two most common genes mutated in familial forms of ALS. That's SOD1 and C9orf72, which I'm sure you've heard of. Now, mutations in both of those genes are most commonly associated with a toxic gain of function. Too much protein is in there causing problems within the cell. And so people have used that to attack those proteins by trying to suppress their production. And the way that that happens is normally, in this slide you see on the right side here, normally DNA is transcribed to what's called RNA, which is kind of the messenger, that then goes out into the cell and helps to produce a protein. Now in the normal situation, that protein is fine, it functions and goes about your business. But if that protein is abnormal, causes a problem, well then you lead to all of those boxes that we were just seeing. So these trials are now using something called antisense oligonucleotides, or ASOs, in order to prevent the production of the abnormal protein. And this is basically how it works. They come into the cell, they actually bind to that sort of intermediary, the RNA, and they prevent the protein from being formed. No protein, no toxic effect. And so this has provided a really, really nice source of research for these genetic forms where we have a very specific target. And tofersen, one of the first ones that was produced out of WashU in Dr. Tim Miller's lab, has already gone through a number of initial trials showing that it is not only safe, but we're now getting some data back suggesting that it is definitely efficacious. And so there's some ongoing trials right now, and we're hoping to see some more data coming out over this next year. More recently, C9orf72, which is perhaps a little bit more exciting because it's a bit more commonly seen in motor neuron disease, is being treated with another ASO in a phase 1 trial that's just started recruiting over the course of this last year and a half or so. And we are a site here and have a patient already getting treated with that. So these are very, very fascinating treatments, and hopefully will provide us a new avenue for developing treatments for so-called sporadic disease. Because right now, these are open only to patients who have mutations in these genes. Now, I put this picture down here just as an illustration. As of right now, both of these treatments are still given what are called intrathecally, meaning into the spinal fluid space via lumbar puncture. Now, so we talked about getting down to the root cause, and we have a lot of exciting treatments coming down from that pathway, but there must be another way to attack all of these boxes here. And one way is to use something that, well, targets multiple areas. Instead of using a single molecule that targets one of these, why can't we do something that hits several of them? And that brings us to talking about some of the cell-based therapies. So instead of using just a single molecule, what if we actually give cells that are able to provide a number of different healthy factors that can improve the health of the motor neurons? And one of the places that this has been most interesting recently are in mesenchymal stem cell trials. Now, these are cells that are taken directly from the patient via a bone marrow aspiration, and those cells are then tweaked in a slight way to make them produce a little bit more of nerve growth factors in order to make them kind of that healthy milieu to get back in and improve the health of the motor neurons. They're then given back, again, intrathecally via the spinal fluid in order to get next to the motor neurons. The companies that are working on trials currently in this form are Brainstorm, which you may have heard of, and CoreStem, which is another company that is in Korea that hasn't had as big of a presence here in the United States as of yet. The trials that are out there are focusing on a product called Neurone, that's from Brainstorm. And the early phases of those trials suggested there was some benefit. And so there's currently a large phase 3 trial, meaning we're really kind of trying to prove that efficacy. And it's ongoing, completed enrollment in September of this last year and should be done toward the end of this year. So we're going to be looking forward to data coming out from that very soon. Neuronata-R is the stem cell therapy that is done through that CoreStem, the Korean company. And they have some early phase trials that have suggested benefit as well, and are currently talking a little bit with the FDA about potentially getting some trials maybe coming toward the United States. Now, on the earlier phases of those trials, you get some fancier ones, like one that was done directly here at Cedars Sinai, where we took neural-derived stem cells and injected them directly into the spinal cord of ALS patients in order to get those cells right next to the motor neurons in order to produce those growth factors and really help them survive. This was a phase 1 trial, basically to prove that we could do it and that it would be safe. And we completed that in 2019, and it looks like we have good safety data, and Dr. Svensson and Dr. Balo will talk with you guys a little bit more about the specifics there later today. An interesting one coming out of Houston is a T regulatory cell infusions, where they take the patient's own cells, isolate these specific immune cells, grow them up, and then give them back into the bloodstream. And it's been shown that in an early phase 1 trial, those infusions may seem to stabilize the disease during that time, and so they've got a new phase 2 trial going on right now. So we've got a lot of very, very interesting ways in which we might be able to attack a lot of these different boxes here, but we still have a lot of other options. So while I sort of downplayed the idea of attacking one or two of these boxes, there's still a lot of other medications that do, and I think that are still worth checking into. So I mentioned a few of these here who are currently either in phase 3, meaning looking for that strong efficacy, or about to start phase 3 in order to get us some more treatments. So levosimendan and arimoclomol are currently in closed trials and should be finishing up within this year. Masitinib is a tough one because the data was a little bit mixed. It was actually denied approval in Europe, but the company is still pursuing it, and we're looking on maybe getting a trial started sometime within this next year. So things to kind of keep on the radar here. Now, that's not the end of the story, as you would imagine. Lots and lots of other medications are being currently tried, and you're either in earlier phases or currently moving into later phases of trials. I'm not going to go into all of these necessarily, but just to make sure that we're keeping a close track on things, there's a lot of interesting ways to kind of attack the disease. One of the more interesting ones you'll see down about 5 or 6 down the path there, Triumeq, which is an antiviral medication, which is used to attack a very specific form of gene change that happens in this disease. And so all of these are still coming down the pike and interesting things to find, but there's so many more. So even if we look back from 1995 to 2017, over 50 trials looking at least 24 different molecules have all been tried, most of which have had negative results, but there's so many to dive through here. How do we even get through all these in a meaningful way and really get that information? Well, what that means for us is that we probably need a different way to do it. And luckily, Dr. Merit-Sukovich and the group at Mass General have come up with a way to do that. And by taking a lesson from the cancer folks, they're actually helping to form what's called a platform trial in medications in ALS, and working with 54 different sites around the country who are supported by NEALS, we're going to get started. And what it's going to allow us to do is, instead of doing a single trial, looking at a single medicine, and then going for a year or two before we have any information, what this allows us to do is look at multiple treatments at the same time, to take less time to get the information, and to use smaller placebo groups, meaning more access to therapeutics for the patients, less time until we get an answer, and ultimately less cost for these very expensive clinical trials. Enrollment's set to begin here within the coming months at a number of sites. I listed the California sites that'll be available there. And I'm going a little short on details for this because I want Dr. Sukovich to be able to give you guys a little bit more information about this when she speaks later today as well. But a very, very exciting path forward for finding that answer. And so I think we're in a really exciting spot. It is very unlikely that we're going to be waiting another 22 years for medication. In fact, I'd be expecting one within the coming year. We're going to be getting a lot of good positive results and a lot of good paths forward. So we have a number of ways to get this going, and here I've just left a couple of websites and things like that in case you have some interest in the trials themselves. And thank you so much for joining us here at Cedars, and again to the ALS Association for having us. And I will get out of the way, but next up we have Tara Jones, who is our licensed genetic counselor here at Cedars Sinai. She's been with us for just over the last year and has been an invaluable resource for both us as the doctors and especially to the patients in her knowledge and her caring. So, Ms. Jones.
Hello, everyone. Dr. Abby also forgot another player in that wheel, the genetic counselor. And when she started talking about missing someone and that they were the most important, I got very excited. And of course, Tammy's the most important. But I want to bring up the fact that for anyone diagnosed with ALS, genetic testing is an option. And I hope that by the end of this talk, it will give you guys some knowledge and items to start considering on whether genetic testing is right for you and your family. What button do I press? The middle, okay, cool. So after receiving an ALS diagnosis, hundreds of things might be coming through your mind, including how did this happen? Why me? What will our future look like? And will my kids get this? And I'm going to focus on this last piece because this is often the reason why people choose to move forward with genetic testing. So let's start with how common ALS is. It is more common in men than women. About 1 in 350 men and 1 in 400 women will develop ALS at some point in their lives. Age of onset is a pretty wide range. You can see that there is overlap with people who have family history versus those who do not. Generally speaking, those with family history have an age of onset that's about 10 years earlier than the people without family history. So looking at ALS as a whole, only about 10% of individuals with ALS do have family history. The other 90% we consider to be sporadic. So what does it mean to have family history? The technical definition is at least 2 related family members with ALS or a related condition. Now, Dr. Balo actually somewhat disagrees with this and thinks that you need to have at least 3 family members to really consider someone to have familial disease. In this diagram, this is a pedigree. When I meet with patients and families, we kind of go through the family history. This square, the blue square, is the patient who came to clinic, diagnosed with ALS at 51 and currently 52. His sister, and in the blue, died at 60 years from ALS that was diagnosed at 57. Their mother died at 45 during childbirth, and their grandfather died at age 70 due to Alzheimer's disease, diagnosed at 60. So what is this other related condition? Many of you may have heard of frontotemporal dementia, or FTD. For those who haven't, it is a type of dementia that's not like your typical Alzheimer's with memory loss as the primary symptom. Rather, FTD affects behavior, executive functioning, language, and emotion. So behaviorally, it might look like an individual becoming a criminal after a lifelong perfect record. They might start spending money recklessly, going out and buying new houses and cars. The executive functioning piece is sort of someone's ability to plan and prioritize. They can have difficulty multitasking and kind of forget what they're doing as they're performing the task. The language piece can look like someone forgetting the vocabulary word of a very common item, such as a pen. People might say their sentences out of order, or they might have trouble understanding language that is spoken to them. And the emotional piece can look like apathy or lack of motivation to do things, lack of impulse control, things like that. And so because of all of these unique symptoms, often FTD can be misdiagnosed as bipolar disorder, schizophrenia, depression, sometimes early onset Alzheimer's. And I do want to point out that having a handful of these symptoms does not mean that one has FTD. In fact, only about 15% of people with ALS meet the diagnostic criteria for FTD. In this picture, you can see FTD really affects the blue frontal lobes and the purple temporal lobes, whereas motor neuron disease, or ALS, causes pathology towards the back of the frontal lobe, down through the brainstem and down the spinal cord. And those who have both diseases can have overlapping regions affected. So what are the chances that one has a genetic mutation? So if you are in that familial range, which is the 10% of people who have ALS, we have identified only about 2/3 of the genetic causes in those cases. So this other 34%, the green part, hopefully you guys aren't colorblind, we kind of suspect that there's just a genetic cause that we have not identified yet. So there's a lot of research being done on people who fit that particular category. If you are in the sporadic category, that other 90% of people with ALS, you can find a genetic mutation in up to 10% of individuals. Now, this varies a lot depending on what ethnic population you are looking at. And it's thought that the sporadic cases that do test positive can be due to many factors. It could be that we have a limited family structure where there weren't many children in the family. People may have died at younger ages, such as the family that I showed previously where the mother died at, I think, age 49. And we can also have lack of knowledge of the family history. Thanksgiving actually happens to be National Family History Day, and so I encourage everyone to really ask your ancestors what information they have, because we're sort of becoming lost in translation when we go beyond a first-degree relative. And there are also certain genetic causes that have incomplete penetrance, which essentially means that family members can have the genetic mutation but live long enough without ever developing the disease. So things to consider when thinking about genetic testing. The first piece is management. At this point in time, genetic testing will not change your medical management. It will not lead to any cure or treatment that's specific to that genetic disease, but it may offer opportunity for participating in gene-specific clinical trials, such as what Dr. Burford mentioned with C9 and SOD1. Those are the two most common genetic causes of familial ALS and FTD. And the second piece is that when you do genetic testing, you are not just testing yourself, you are really opening Pandora's box to other family members that could be at risk. And so I typically recommend that patients go home and discuss with their family members that they're considering doing this testing, just so you can kind of make sure that everyone's on the same page. And then the last piece is insurance coverage. So because ALS is an adult onset disease with no specific treatment or cure that's going to delay its onset or stop the progression, insurance companies tend to not reimburse for this kind of testing. They don't see the clinical trials as something that is medically necessary until that drug becomes FDA approved. Another thing to consider is that prior authorization is not guarantee of payment. So once the genetic testing is done and insurance is billed for the testing, they can kind of go back and say, we don't see enough medical necessity from this, so we are going to deny reimbursement. So in these cases, I typically recommend, if it's affordable to families, to consider the cash pay, because you know what you're paying up front. And genetic testing has really gone down in prices these days, and currently we can do a very comprehensive panel for under $1,000. Another option rather than genetic testing is DNA banking. And so this is done really for family members to have in the future. Recommended for familial cases who test negative and we can't find the genetic cause, as well as for people with ALS who don't want to know their own genetics, but perhaps their family members will down the line. This process involves collecting blood, and the lab that stores the DNA will isolate the DNA from the blood, and they can keep it for many years. There can be either a one-time fee or monthly or yearly fee, and then typically additional fees to take that DNA out and send it to a clinical lab for testing. But there's hope that, 5-10 years from now, we will learn of many other causative genes that can cause ALS. I also want to point out tissue donation. After one dies, it can be very helpful in kind of uncovering the genetic causes of ALS and many other things. So here are my references. If anyone wants to look through any of these, you can reach out to me afterwards, and I'm happy to provide those. And for those of you who don't come to Cedars for clinic, you can find a genetic counselor on this website, findageneticcounselor.com. You might be able to find a genetic counselor who specializes in adult or neurology conditions locally in your area, and there are some genetic counselors that offer telegenetic counseling over video or telephone. So that is the end of my session.
Hi, you mentioned tissue donation, and somewhere a year ago I saw something about donating your ALS brain for research. Where do you find out where to have it sent?
That's a good question. So patients who are part of our ALS clinic here at Cedars, we do have a tissue donation program. Tammy, the program coordinator, can definitely facilitate that. Otherwise, I don't know of a central spot to find places that you can donate tissue, but I would recommend reaching out to local academic medical centers because most of them will have a brain bank.
If you don't mind, I'd like to ask a specific question about a particular drug. You may or may not know anything about it. It's called Prostetin, Prostetin, apparently being done by Project ALS in Columbia. Do you know anything about that drug at all?
I don't know any specifics about any data coming out from that. I've heard of it. I know the trial ongoing currently, but I haven't heard any new data recently. I apologize.
Good afternoon. Is there any possibility of getting copies of your slides that we would be able to look at them later through some kind of website?
I think they may be provided, but we'll have to check with the sponsors. I have no problem with that myself.
As long as it's okay with you, we can make them available to everybody, yeah.
So how would we do that? How would we find that?
We have you on the registration list, and we'll let everybody know who's on the registration list, when they're available for downloading.
So it sounds like they'll get the slides set up online and let the folks know who are registered how those will be available to you.
Sorry, stem cells. Are you already coming with the ones that are already here, the neuron? I'm sorry, my English is poor, second language. However, last week exactly, in our support group of ALS, there was an individual who was diagnosed 14 years ago, and guess what? He did the daring thing that he went to China and did stem cells with the embryonic whatever cells or that, and it's 14 years, and he speaks better than my husband who has ALS, and he was diagnosed a year and a half. It's amazing. It's amazing. It's like he lost the use of his hands, but he is able to walk. And as I said, his mind, his voice, everything is sharp. And it's 14 years. And I was like, I couldn't believe it when I thought he was, yes, that's what happened. So tell me about it when. We have the right to whatever we can do. I mean, is that something available? It's not available in the United States, I know. But there's the Dr. Riordan in Panama. Dr. Riordan, you're familiar with, he has had a lot of success in MS and also in spinal cord.
So what I would say is there are a lot of single stories like that out there, and it's very challenging to know what they mean. So is it true that the stem cells that the patient was receiving allowed them to live that long? Or would they just be one of the minority of patients that is a slow or minimal progressor? And that's very difficult to say. Ultimately, it's very important to focus on the proven treatments that we have. There are many, many, many stem cell clinics in the world that will take your money and they'll give you something with a lot of big claims. But none of those are proven, which is part of the reason that these trials are so, so important. There certainly are places around the world, some places in China that will do that. It will cost an arm and a leg to do it, but there's no proven treatments out there at the moment. And so I talk to a lot of patients about this because, as I mentioned, a lot of these stories are out there. But you should be very cautious and you should be very skeptical of those, only because we don't know yet. And so the things that we should trust are the things that we have the evidence for. And especially if pursuing those types of treatments is going to put you out financially or cause any undue burden, then it should certainly be avoided. But if you have interest in those things, I encourage you to talk to your doctor about it, because there certainly are options, and you're right. You have the right to pursue any treatment that you feel is worthwhile. But it's important to make sure that you have all the information about it by talking with your doctor and kind of reviewing the evidence.
Have you been in that, I imagine you, Dr. Riordan, in Panama, he's in the university here in the United States. He is an expert on that field. That's it, precisely, he's a genius or whatever on that field. And I'm thinking, if he's going into MS and also for spinal cord injury, make them they come back, they are walking, people who have been completely separated in the spinal cord and is walking. His name is Riordan, last name, and you just go over there. He is unbelievable success. And now I'm thinking, he is here in the United States. He does, however, because of the not allowing to use certain types of cells, blah, 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 blah. But however, as we go to, I'm thinking, we're desperate people, so I want you to know, right, we're desperate.
But that's exactly the reason to be skeptical about those stories, because a lot of folks will peddle in false hope. They will make extraordinary claims about things that are very unproven. And so it's very, very important, so important, to focus on the information that we have, the evidence that we have, and to continue to talk with your doctors about what's going to be the best decision for you. I'm more than willing to take a look at the evidence that's out there in these stories, but as of right now, I don't know of any that is that extraordinary. So remain skeptical, but continue to have the discussion.
Can Radicava and Riluzole be taken at the same time?
Yes, absolutely.
I didn't see it myself, but I heard from someone who watched a 60-minute segment on the possibility of curing sickle cell anemia with HIV cells. Is that something you've heard of? And could it be possible for ALS?
Yes, absolutely. So it's not HIV, it's AAV, which is a different type of virus that's often used to deliver certain gene therapies. And so sickle cell disease, which is a single gene mutation, is easily targeted by those types of treatments. And I mentioned a few different types of ways to target genes in ALS with the so-called ASO treatments, but these viral vectors are also being looked into. And they've been very successful not only in sickle cell, but also in spinal muscular atrophy, which is another inherited motor neuron disorder. And so I think that there certainly is quite a bit of work to be done and potential positive results for that.
We have a question right here. Actually, we're going to steal your mic.
I actually have a couple questions. One is, just yesterday on the ALS News Twitter page, they posted a video that was titled "How to Stop ALS in 2020." And on that video, it highlights 3 available treatments that have either slowed down or stopped the progression of ALS symptoms in patients. And you had those up on the screen earlier today. One was the T-reg procedure that doctors at Appel in Houston. And much to my surprise, on the video, he was emphatic and used the words stopped the progression of symptoms. He didn't use slowed down, he used stopped. The other one was the one in Australia, the copper ASTS one. And they, in the video, the doctors there said it slowed progression by 70%. And then the third one is the neuron one. And the video states that as of January 10th, just this month, 2020, they identified 15 people in the neuron phase 3 trial who stopped getting worse, who actually got better. And they found that it has helped up to 40 to 50% of the people. Now, the only solution to having that get into this community is 2 ways. Either President Trump has to do an executive order, or, which is not out of the possibility because he did one for liver transplants. The second one is that the FDA could give conditional approval. And when you talk about people who have heard good things, there's no worse burden for an ALS patient to be told than that they're going to die in 2 to 5 years. And Matt Bellina, who was the individual who the Right to Try Act is named after, he's the only person in America who was allowed to have the neuron treatment who's not in a trial. And I had the opportunity to go to Matt Bellina's house and met him. And I saw somebody in their 7th year who was a quadriplegic stand up. And in the video that the ALS showed on the internet yesterday, it shows Matt doing squats. I met Matt who had breathing apparatus for 2 years, now breathing 100% on his own. It showed Matt who couldn't use his hands, using his hands to put his glasses on. And he was in his 7th year, not his first 2. So the question is, where and when is the movement going to happen for the people in this room and other rooms have ALS? Because these things, and I compare it to cancer and oncology. My wife and my mother both are cancer survivors. And when you go to an oncologist, they try different treatments. And the oncology and chemotherapy does not work for every cancer patient. but it does work for a lot of cancer survivors. And if these 3 treatments that are mentioned in the video and the other ones you had up on the screen, they may not be helping, Neuron's not helping 50% of the people, but it is helping 50%. These other studies are not helping everybody, but they're helping 70% and 30%. So my question is, when are the clinics going to move from a management approach to a treatment approach? Because I think every ALS patient in this room who went to a clinic was not told about a cure. They were told about come back when you need a feeding tube or come back when you need a wheelchair. And it's great, and the work that the clinics do in that area is phenomenal. But what ALS people want to hear is they want to sit down with a neurologist at a clinic and be told what a viable treatment could be.
Yes.
And that's not a question, that's just a comment. So, do you agree with that, ALS patients?
We can make a movement here. Let's go to Washington.
That's what we're all looking for. Now, again, we have to be careful because some of that information is difficult to interpret. The trial that was done with the Tregs was 3 patients. 3 patients initially. We don't have a lot of information there. It looks great, absolutely, it looks great. And Dr. Pell and and the folks at Mass General are working on getting that information. But we need the information. We can't focus on the single stories, the pieces of data. We want to move forward as quickly as possible, but we still have to get the information correct. And so we can't take the video that gets posted and say, all right, we're going to do all the treatments, because the FDA won't allow that. We've got to move forward. We've got to talk with the FDA. We've got to talk with Trump and the administration about getting these things facilitated through. And even as we're working on getting the trials and the real data to say, who are the people that get the 70% benefit? Because those are the people that we need to be getting this treatment to right away. We need to get that tentative approval so that we can move forward with that, because right now we just don't have the ability. And so ultimately, we need the information, and the trials are going to let us do that. Our platform trial, you alluded to cancer treatments, that's exactly what we're going after with that, in order to allow us to very quickly get to that information. What's working, what's not working, and get it into the clinic, because that's what we all want. And so we're working on it, I promise you. And it's slow, and it's tedious, and it's frustrating for everybody. But that's why we got to keep having these discussions. That's why we got to keep coming to these things. That's why we got to keep hearing from you and from you about all of the stories that you're hearing, because there's so much out there. No one can keep track of everything. And so we've all got to keep pushing in our own way to move the ball forward. And that's how we're going to get that treatment out there. And that's how we're going to ultimately get the cure. So I think we might be out of time, but
Thank you so much. Just wanted to say we have one more question from the audience, and we have 2 brief questions from the internet. And for all of you who are watching online or here today, you can always send your questions to us today or after the fact at AsktheExperts@alsagoldenwest.org.
Can you elaborate on your own stem cell research? What kind of people, what kind of patients would qualify for the treatment when it is over, when your trial is over? Or at what level or which year can these patients become join the trial?
Yeah, so ultimately, the trial itself is closed to enrollment currently. The inclusion-exclusion criteria for that trial was a little bit odd, different from other trials. And so there was an age limit of 60 years old, which was very atypical. And they had sort of a set progression that they wanted to see over the first 4 months. Now, typically, I would say that those trial criteria will not necessarily be the same criteria that they use to determine who gets the treatment once it is, or if it is, approved. Usually once that's set and they get that information, most often things are approved for all ALS patients, period. End of story. And so that would be the hope. But we do have to see what the FDA ultimately thinks of that given the actual trial inclusion-exclusion criteria. Usually the bigger fight there is actually with insurance that looks at the trial and says, oh, you don't fit the trial criteria, and then we have to yell at them and make them pay for it anyway. But usually it should be all patients once we get that approval. Sorry? So that'll depend on the data ultimately. So trial is still ongoing. We don't have much interim data as of yet, but we'll have the last patient finish the trial at presumably September of this year. We'll be getting some analysis of the data, and as long as things look positive, they should very quickly move through the FDA. Hopefully within the next year, we'll have more information about an approval decision.
Thank you so much. We have one more question from the audience and one question from the internet.
Hi there. I'm actually speaking for my sister. She was diagnosed 2 months ago with the familial C9orf72 gene, and she just wanted to know what's the best way to find a clinical trial for that, since she was diagnosed with the familial gene, so she can get on a trial. What's the best way, the easiest way? I know you put a bunch of information regarding clinical trials, but yeah, so that's her question.
Yeah, of course. So with C9, there are a number of sites around the country that are focusing on that trial. I would encourage you actually to either talk with your doctor, or you can actually get in touch with our office and we can potentially help facilitate getting you in touch with either the site here, because we're a center for that, or other sites, whatever would be most convenient.
Thank you. We have a question from the internet. Are SOD1 and C9orf72 only involved with patients that have genetic ALS?
I'm going to let our genetic counselor handle that one.
So those are the two most common causes. C9 accounts for about 25 to 30% of cases, and SOD1, I believe, about 10%. But there are up to 24 different genes on top of C9 that have been identified to be associated with ALS, FTD, or both diseases. And we're still learning of more. So those are the two that have clinical trials currently, most presumably because they'll have a larger population to test. But there's a lot of research being done on opening up clinical trials for some of the other genetic causes as well.
Thank you so much. And the final comment from the internet was, just a comment, thank you for streaming this on the internet. I love all you guys at Clinic. Thank you to our presenters.
Hi everybody, welcome. My name's Asher Garfinkel. I'm the Vice President of Community Outreach for the ALS Association Golden West Chapter. I just wanted to take about 60 seconds to thank a very important part of today that helped today make today possible, as well as all of these participants make your care possible. They help improve lives on a daily basis, and they are our many sponsors for today. So I, of course, want to thank our hosts today. That's Cedars Sinai. Thank you to everybody at the Cedars Clinic. Thank you to Superior Mobility. Thank you, Brett and David, for being here. Thank you to Quantum. Thank you to Mitsubishi Tanabe Pharma America. And thank you to iGaze. And we will be having a break a little later, and we want to make sure that you have the opportunity to go speak to representatives of all these wonderful companies that are supporting this effort today. And now I'd like to introduce a relatively new face to the Golden West chapter, a wonderful addition to the staff, and she's helping to make things happen. She is our Chief Operating Officer Sheri Strahl.
Well, thank you, Asher. I get to thank our sponsor, New Motion. Thanks, New Motion, for also helping us bring this event to everybody today. Welcome. It's an absolute honor to be here and to serve, and thanks to all of you for coming out today, and for those of you who have joined us online. At the ALS Association Golden West Chapter, we are proud to say that everything we do advances the search for effective treatments and cures for ALS. At the heart of this is our staff. Every day I see talented, compassionate people throughout this organization working tirelessly to do their part to defeat ALS, all driven by our core value that people with ALS and their families come first. You will find chapter team members at clinic visits, hosting support groups, facilitating equipment loans, and homes working with families, organizing community outreach events, on government steps, advocating for important public policy initiatives, and leading awareness and fundraising efforts. This year alone, the Golden West Chapter will have provided assistance to more than 1,800 people with ALS and their families. I thank our dedicated team for their compassion, selflessness, and excellence. In turn, it is people who are facing this devastating disease who are helping to drive progress in the fight against ALS. And we are celebrating one of those individuals here today. Jim Barber was a Vietnam War veteran and a graduate of University of California, Santa Barbara, and the UC Hastings College of Law. He was a successful attorney for more than 30 years before he was diagnosed with ALS in 2006. During his nearly decade-long battle with this disease, Jim became an instrumental voice in the ALS community. He helped create the California ALS Advocacy Committee, whose work resulted in the passage of 2 bills. The ALS Standard of Care Bill, which stated the highest standard of care for people with ALS in the California Health Code, and the California Tax Checkoff Bill, which to date has raised more than $600,000 for ALS research. In addition, along with other advocates, Jim helped with securing a pivotal $18 million grant for ALS research from the California Institute for Regenerative Medicine, also known as CIRM. The ALS Association and the Golden West Chapter recognized Jim for his work by honoring him with the Iron Horse Award in 2010 and the Heroes Living with ALS Award in 2011 and again in 2016. A major outcome of Jim's work was the formation of the California ALS Research Network in 2010 and the creation of the California ALS Research Summit in 2011. Jim Barber held a deep passion and commitment to the ALS Association's vision to create a world without ALS. It was his desire that the annual ALS Research Summit would encourage collaboration and the sharing of ideas, as well as give special recognition to those participating researchers. Beginning with the 2017 summit and continuing annually, the Barber family and the Golden West Chapter presents 3 cash awards of $1,000 to each of the top poster presenters, along with a special memento recognizing their accomplishment. These winners are also invited to present their posters here at the Ask the Experts event, and then later at the Golden West Chapter board meeting in San Francisco, happening actually next weekend. So it was just yesterday that many postdocs and young scientists presented their ideas in a robust poster presentation session here at the Research Summit to some of the leading ALS researchers and clinicians. 3 individuals were selected for their achievements and will be presenting their posters to you this afternoon. And I would now like to invite some of those who evaluated this work to share with us just a little bit about what's a poster presentation. Please welcome, From the Center for Restorative Neurology at Loma Linda University Health, a certified treatment center of excellence of the ALS Association, the medical director, Dr. Jeffrey Rosenfeld. Yes. And also join me in welcoming internationally renowned research nurse and winner of the Lawrence A. Rand Prize, an annual award that recognizes the courage, passion, integrity, and commitment of those serving the ALS community as volunteers, healthcare professionals, educators, communicators, or in other ways, contributing to the quality of life of people living with ALS. Dallas Forshew, RN.
Well, we both thank you, the ALS Association, for inviting us here. I'm Dallas, of course, and this is Dr. Rosenfeld, just in case you got things confused. So, the elements of a scientific poster. I'm going to spend 2 minutes on this, but you will see these sections in every poster. So there's always going to be an introduction or a background section where the poster presenter says, why did I do this anyway? Why is this research important? States the problem, and then goes through their objective. What do they hope to learn? Hypothesis, aims, what are you adding to the current knowledge? What do you hope to gain from the information in this? Methods are very important. So methods are study design. Basically, how did they do the research? And a research project can live or die on good methods or poor methods. The data is, okay, what did we find out? Results in summary are usually bullet points of what did the data show? And then finally, some conclusions where the poster presenter interprets the results and makes recommendations. So that's just a basic overview. And now we're going to have our...
Just to make
a
comment.
Please.
Sure. Just wanted to add one. I'm very happy to be here to help with this fairly new format for ALSA. In the past, we've mostly focused on the results and have the young scientists talk about their data. But this year, I believe the focus is on the process. That is, what does it take to actually put a poster together, to have a research idea, the time, the effort, the logistics. The data itself will certainly be explained, but it may or may not be understandable or relevant to you. This is all about giving you an appreciation for how it is that you put together a presentation that in these three cases won an award that was very competitive. Presenting a poster is like telling a story. You know, so just like if you had an anecdote that you wanted to share, you'd find a way in a concise manner to tell that story. So Dallas just outlined the elements of the story. In science, those elements are always present. When you're listening to the story at the poster, when everybody came by to talk to them yesterday, their job is to tell that story in as few words as possible to make you excited to want to ask more questions. It's a game, right? They teach that game when you're a graduate student, they practice that game when you're a postdoc, and then you play that game for the rest of your career. Okay, so today what you're going to hear is we call it the elevator pitch, the 2-minute presentation of what they did, and then we're going to have a little question back and forth. Okay? So.
So, hello, I'm Maya. I'm from Stanford University, and I'm going to present my work today. I'm interested in mechanism underlying cell death and axonal degeneration, and in trying to find out what is responsible for those axonal degeneration. I took neurons from the brains of the mouse, and I plated them on a dish, and to those I added the TDP43 or C9orf72. Those are the ALS-associated proteins. And those proteins cause axonal degeneration. So this is the puncture formation that you can see up there. And trying to find the mechanism that underlies those axonal degeneration, I extracted either DNA, RNA, and protein, and I found this master regulator called P53, which is a transcription factor. This is a gene that is responsible for the regulation and expression of other genes. And in order to find out if it is indeed required for cell death and axonal degeneration, I inhibited it, I deleted it, and those neurons that were deleted of P53, they actually survived much longer and they did not degenerate. And I wanted to recapitulate these findings also in vivo, and for that I injected the mice with the PR, the toxic factor, and those mice actually die after 40 days, but with the P53 knockout mice, those mice that are ablated with this transcription factor, they actually survive much better, and so extended their lifespan by 2.5. This is it.
So can you say a bit about where you hope this goes next? What would be the next step in this project?
So actually what I'm working now is trying to find out what's the regulators of P53. And so P53 is known to have post-translational modification, which are changes of the protein. And by trying to pursue this mechanism, I'm hoping maybe we can see a specific pattern that we can pursue later on.
And ultimately, how would it get to something that might reach the clinic?
So if we could find like inhibitors for those specific proteins that are responsible for those modifications, maybe we can...
Administering those proteins could help survival of motor neurons.
Yeah, either pharmacologically or...
Can you say a bit about where this idea came from? How did you come up with this idea?
Yes. So if you think about ALS, you have huge amounts of genes, so it's not just one gene that causes the disease. And so it made me think that maybe it could be the regulation of the genes themselves rather than a specific gene. And so this is what is called epigenetic, it's above the genetics. And trying to pursue that, I used a relatively new methodology that was invented in Stanford, the ATAC-seq, in order to find these.
So what she just said, that's one of the main questions we have in a lot of genetic studies. That is, we carry a notion that a gene causes a disease. But that might not be entirely true all the time. Sometimes it's a gene in the presence of another gene, in the presence of a certain environmental factor. So this kind of study, as I understand it, really gets to the heart of that question. And just one or two more things before we move on. How long did it take you to do this project?
So this is a project of three and a half years. No.
And during that 3.5 years, was this the only thing you worked on, or did you work on other projects also?
Oh, this is the only project.
So now that this project is completed to this poster,
yes.
You started another project from the beginning, or had you been developing projects along the way?
So I think for this, there is a few avenues to continue. One is the regulation, what controls P53, this transcription factor. The others were findings from these transcripts that were found here. So there is other leads that can be.
So it's very common, and I think you'd agree, it's very common that there are multiple projects ongoing in any one lab at a time, some further along than others. And so it's not as if, okay, we're done with the project, let's go on vacation, we'll come back and start from fresh. You know, there's always something percolating. Is that fair to say for your project?
Yeah.
Okay. One last question that you probably don't know the answer to, but I think they might be interested. Do you have any idea what it costs to do that project?
How much it cost? Oh.
Now, in fairness, before I put her on the spot that I already did, but in fairness, most of the time, somebody working in the lab wouldn't know that answer, because the lab chief is responsible for keeping funds flowing. And there's many projects going on in your lab. I know that lab very well, so I know there's many projects. So all she knows is if she orders the reagents, they come in. And I suspect you're not really sure what the reagents cost, because the
reagents, I know how much they cost.
Okay, go for it then.
But knowing how much like the whole project cost, it's, yeah, I'm...
Want to guess?
If I would have to guess, wow, it's difficult. Just the animal facility is so expensive in Stanford.
Right.
I guess it's...
So how many people worked on the project? Was it just you?
Actually, this project is a collaboration in between 10 different labs in the US. And so this wasn't... This was a total collaboration. And so if I have to add those, I really don't know how much.
No, I was just referring, that would be way too much to ask, but for your lab. It's a big number. I don't know the number myself on this project, but they're very expensive because, of course, that's not the only thing they're doing with the supplies that they purchase for this, but it's quite a costly endeavor. Yeah. Anything else? Okay. All right, let's go on to Michael. Yeah.
Hi, I'm Michael Baughn, and my poster is titled Strategies to Develop a Molecular Therapy for TDP-43-Dependent Stathmin-2 RNA Misprocessing in Amyotrophic Lateral Sclerosis and Frontotemporal Dementia. And I realize that that is a mouthful, and when I say something like this to my parents, they're basically like, yeah, I got like 2 or 3 of those words. So I'm going to try and walk through like what this poster means and what the research means. If I were to try and explain the central dogma of molecular biology to a non-biologist, I would need some kind of a metaphor. So the one that I sort of use is if you think of the machines of a cell as the proteins, then you need instructions to be able to build those machines. And those instructions are encoded in DNA. Now, the DNA copy you can think of as maybe being like the Word document on an author's computer. It's got all the information there, but it needs some editing, maybe some typesetting, some chapters added or removed. There could be an abridged copy. All of this editing happens at the RNA level. So you have DNA that encodes RNA, and then that finished processed RNA is the finished instruction set to build your protein, which is your machine in the cell. And so what we're doing is we're looking at RNA processing defects that happen. So if that instruction packet doesn't have the right information in it, then you can't possibly make the right protein at the right time. And so what happens just as sort of a little bit of background, so ASO therapies targeting SOD1 and C9orf72, and then there's some nascent stuff in FAST-TLS. Those started in our laboratory. So I'm from Don Cleveland's laboratory. The first use of ASO drugs in the central nervous system was pioneered by Don about 15 years ago with SOD1, the first identified genetic cause of ALS, and now C9orf72 right after that. So in my pre-graduate work, I worked on C9orf72, but those two causes of ALS combined is about 16.5%. So if you carry those mutations and you're interested in those trials, that's great, but what about everybody else? So really the gold standard of what we're trying to do is find some common mechanism that we could target therapeutically in all of ALS. So the rest of the 95%. So what we've known since 2006 is this RNA binding protein. So you can think of it as a machine that's like taking the printing press and managing it for making that processed RNA. This RNA binding protein, TDP-43, gets put into the wrong place in the cell in 95% of ALS patients. So if you take a cell and you stress it, you can force TDP-43 to move away from what is sort of the factory floor for making these RNA instructions. So it'll get cleared from the nucleus. It's like pulling the fire alarm in the factory, and then the TDP-43 goes out and waits in the parking lot until it's get the all clear to go back in. The parking lot is a dangerous place for TDP-43 because it can get mugged there if it stays there too long, and then it can't really go back into the nucleus and do its job again. And when that RNA processing machinery that it's overseeing is unattended, then you can make mistakes. You can include chapters or remove chapters in the instructions, and maybe that causes problems down the line. So we know that if you remove TDP-43 from doing its job in the cell, you get about 1,500 different RNA processing changes. And so that's a really daunting problem to walk into as a scientist, because we can't fix 1,500 changes all at once. We need to prioritize. And so a really brilliant scientist in our lab, Zevik Melamed, who's a postdoctoral fellow, found a way to prioritize these changes by removing the instructions for this TDP-43 from the cells, and then looking at, in motor neurons, what are the instructions that are in the highest demand in those cells? And when you remove TDP-43 from this regulatory role, what gets most messed up? And the answer to that question is this gene Stathmin2. And so that's great in a cellular context, but does it matter in patients? So the next thing that we did is we looked at a data set that I actually generated with John Ravitz in 2011, where we looked at these RNA instructions from the motor neurons of patients who had passed away from ALS and compared them to control patients. And what we found is that the exact same changes to those instructions that we found in the cell level, we could find those in the patients. And if so okay, there's a disease connection there. So does the protein matter for neurons? If you take the instructions encoding the Stathmin2 protein and you remove them from the cell and you chop off neurons in a dish, after about a day they'll regrow about 300 microns. But if you don't have the instructions for this one protein Stathmin2, they don't regrow. Importantly, if you remove TDP-43 from its regulatory role in those cells, the neurons also can't regrow after damage.
So let me just interject if I could.
Yeah.
Maybe you can, on that issue with the axonal regrowth, maybe you can talk about the implications of this. So where do you hope this result is going to lead ultimately towards a treatment?
Right, so we're not targeting necessarily TDP-43 to go back to its regulatory role. We want to be able to compensate for its loss, even in its absence. And so if Stathmin2 is a really important factor in neuron regrowth, our hope is that we can alter the changes that happen to the RNA of Stathmin2 to put the correct instruction set to be able to build that machinery, that protein, to allow the axons to regrow in the ALS context.
So the benefit of this work is then you've identified or further work on a protein that seems to be very important to keeping motor cells alive.
Right, and not only that, but we've identified what's going wrong, and we're also have identified some candidate antisense oligonucleotides to be able to fix that change.
And how long were you working on this project?
This project is one of 3 projects that I have in the lab, but it's the brainchild of Zevik Melamed, and then there's a team of 4 people in our lab, and then a bunch of people at Ionis Pharmaceuticals that we're collaborating with to try and turn this into a therapy. And so to answer your question, this has been probably 3.5 years in the making.
Okay. So I want to ask you one final question, because it was a question that I was asked early in my career when I was taking somebody through my lab, and it was such a simple question, and really took me by surprise. They said, how do you know that the thing you're working on, somebody in another place isn't working on that same thing?
Oh, we hope they are. Yeah, so
that's a good answer. He hopes that somebody else is doing the same thing.
Yeah, and it was actually very encouraging at this conference to see other labs working on this, and to not only confirm in other patient tissue banks that they see the same changes that we do, but also to sort of take that and move it further in directions that we agree are the right direction.
But you want to be the first one to report it. It's great that somebody else is working on it, as long as you get to the microphone first.
Researchers get paid in terms of publications. So
So that's the currency of research, is publications, and this is a stepping stone. So presumably this will make it into print.
Yeah. So the initial discovery and work was published in January of last year, and then the therapy development is ongoing. So we're making mouse models to be able to test and further that development.
Sure.
And I think it's really important to note, and patients love to hear about collaboration. So the first 2 posters, and I bet our third, have had multiple collaborators across multiple institutions, and including some industry collaborations as well. So I always hear this thing from patients, nobody talks to each other. Well, yeah, they do. They really do. This is a good thing.
Yeah, so we actually, our lab, because of the ASO background, sort of has a special relationship with Ionis Pharmaceuticals. So about once a month we go and meet with them, and it's basically like an open lab notebook thing. Anything that's far enough along that we think is going to be translatable, we'll say, hey, we think you should work on this. And they are really, really excellent. They don't say no.
Yeah.
You know, you don't need.
It helps that they're down the road too, that they're so close to you.
Yeah, of course. Yeah.
Yeah.
So
all right, let's
just as an example of that. So like when C9orf72 was first discovered, literally the next day we met with Ionis and came up with a plan to use ASOs to do it. So.
Okay. Thank you very much. Okay.
Hi everyone, my name is Veronica and I'm a postdoctoral scientist here at Cedars Sinai, and I'm working with stem cells, and the goal of my research is to kind of create a completely human model to describe what's going on in the relation to ALS, specifically with C9orf mutations. So the title of my poster is C9orf ALS patient iPSC-derived cortical neurons and astrocytes display disease-specific phenotypes. So I'm looking at the cortex, which is a somewhat understudied region when it comes to tissues involved in ALS. And in your brain, or your cortex, you've got neurons, your main brain cells, and then there's support cells, which are the astrocytes. And so what I've done is, using protocols to the best of kind of human ability, I've made these two different cell types from 10 control normal patient lines and 10 C9 ALS lines. And then once I have these two different cell types with all the from different individuals, because of course we're all very diverse, and so you want to really quantify a disease-specific phenotype that's kind of conserved across more than just a few individuals. So once I have my cells, I then started characterizing them. And the first thing is with the astrocytes, I use a human cortical fetal sample. So these are like embryonic cells, because I want to know, comparing my stem cell-derived cells, how do they look compared to nature-made cells. And basically, the control and the ALS lines, they all look pretty good. They all look like astrocytes. When I start looking at the electrophysiology, or like the function of the cells, they also have the same sort of maturation. So there's no real differences in the populations between the control and the ALS. However, I did find one tiny difference where they have an increased input resistance. And what that means is astrocytes, in order to be supportive, they have to have all the right proteins in their cell membranes, and it seems like the C9 ALS astrocytes might have just a couple less than the control. So then I looked at the RNA that's expressed by these astrocytes, and those are the transcripts that turn into the proteins, and it looks like not only do the C9 and control astrocytes have similar amounts of all these proteins, two very important proteins, the SPARC and TSP1, they're involved in forming synapses. So they're especially important in helping neurons talk to each other. And it looks like the C9 ALS astrocytes might even be expressing a little bit more of these proteins. So it gets interesting, because then I took these astrocytes and I put them with the control or the ALS-derived neurons. And when we look in the top graph, it's pretty small, the neurons are very quiet. They need the astrocytes with them in order to kind of talk and function with each other. When I have control astrocytes with both the C9 and the control neurons, they're very talkative. There's a lot of activity. But when I have them with the C9 astrocytes, even though they might be having a little bit more supportive protein expression, they're much quieter. It's almost to the level as if there were no astrocytes there at all. So that's kind of, we're hanging our hat on that for a moment, and we're going to turn and look at the neurons. So the protocol that I use follows embryonic development, and so it gives me a whole population of different cell types. And I want to know, the control in the ALS neurons, are they making the same correct types of cells, and it turns out they are. So there's no real obvious difference in the neurons I'm getting from these stem cell lines. So then I'm looking at their electrophysiology and how they talk to each other, and it turns out when I'm looking at the entire population, there's a lot of diversity in the cell types, and so it's kind of muting any sort of differences between the disease types. So I have to start strategizing how to look at specific neuron populations, and I started by separating by the size of the cells, and it turns out there are differences in some of these current conductances between C9 and ALS. So we're starting to find that there's differences in the proteins that these neurons and astrocytes have in the way that they speak to each other. And so I'm further looking at more global studies using calcium imaging, where I can look at hundreds of cells all at once instead of individually, and then also characterizing if they have this typical proteins that have already been associated in ALS, such as TDP43 or stress granule formation.
Thank you very much. Can you say a few words about how the implications of this trial might result in something, a new treatment, for example?
Absolutely. So right now I'm trying to figure out essentially how it's broken. And although I've identified a couple different pieces, the next steps of my research is trying to figure out how these pieces tie together, how ion channels in the astrocytes affect ion channels in the neurons. And so once we identify some targets, then that leads to therapeutic design or potentials for a small molecule inhibition or overexpression or knockdown with ASOs. So I'm really looking for like key players that are existing in these cell types before they even get sick and die. So I'm not seeing any cell death.
Sure.
This is earlier on.
It's a great project, and your lab here at Cedars Sinai is a very big lab with many, many projects in lots of directions. So this idea, was it given to you to work on, or did you come up with this on your own?
So this idea actually started with a former postdoctoral scientist in the lab, Gretchen Thompson, and she came in with this hypothesis that ALS starts in the cortex. And funny enough, our PI, Clive Svensson, was kind of like, oh, I'm not so sure about that, it's in the spinal cord. But then Gretchen showed with animal models that it does happen, that there's an effect if you knock down the specific proteins in the cortex, that it has an effect on the motor neuron death in the spinal cord.
Right. So that's a very common scenario, where the lab is like a lot of moving parts, and everybody, how many people are in your lab, would you say?
Oh, I think like 25.
Right, so 25 scientists and technicians working on many different projects, but they're not islands. So when somebody new joins a lab, like back when you joined the lab, it's not as if figure it out. Usually there's a piece that's carved out, and in this case it came from Dr. Thompson, who also was a very productive scientist in that lab, who moved on to a different position, and you kind of inherited that project to take it the next step forward. So that's a very common scenario. Mm-hmm. And how long did this project take you to work on?
From the time that I kind of was handed off, because Gretchen kind of went more towards the animal studies, I'd say I've spent about 4 years on this.
4 years?
Yeah.
I'd ask you how much it costs, but I know you're not going to know that.
I do know.
Do you really?
An estimate. Guys, it's hundreds of thousands of dollars.
Yeah.
Yeah.
Hundreds of thousands of dollars to do the,
for
do
4
the project.
years.
So, and it's one step. It's a critical step to get to the next step that hopefully you'll do, or you or the persons that come after you will do. Yeah. Anything else? Thank you. Yeah. I thank all three of you. I know this elevator speech thing is a little new still, but I had a mentor that once told me, if you can't say it in 30 seconds, don't say anything. But, you know, so, yeah. Thank you. Questions? Really? Do we have time for questions? I guess we do.
Just 1 second, please.
As everyone here has a concern about the timing of treatment and therapies, it's an ignorant question, but what if instead of 25 people in your lab, you had 50? Could you accelerate the timing on your studies?
That's a great question. Do you want to answer that first, or I can answer? You can. You want to generate an answer? Any of you, really, the same question. If your lab had more people, would you get to the answer faster?
So, to to have it's kind of like science in general. The more collaboration and the more people thinking outside the box, the better. So our lab, although we have 25 people, the expertise of each scientist is very different, and it gives us an ability to see things from different angles. So if we had multiples of the different expertise, it might help.
Is that something that the ALS Association could facilitate to help you guys accelerate your research to get treatment faster?
So I think the way I view it is when you do science open and collaborative, going to such meeting and presenting unpublished work, it kind of facilitates the opportunity for other people to look at other organisms or other models, and also, we got got this finding supports this finding, and so I think rather than looking on an individual lab, the way doing science more open and collaborative, facilitated by ALS Association or Target ALS or other consortium, enables to, I think, to speed things up. And also meeting with physicians and with industry. So it's not only the one lab. So this is...
That's a very good answer. I was going to say something very similar. So it's really not a matter of just brute force more people. That is always helpful, but I suspect the lab didn't always have 25 scientists. In fact, I know it didn't, because I knew that lab when they had 10 scientists, and then it got more and more. But it's not just that lab. It's a very interactive and collaborative arrangement. Money is very helpful to drive the wheels of science, but if you had $1 trillion to put into this problem, the answer would not be tomorrow, because it doesn't happen like that. You have to evolve the science. Now, the money is helpful because it makes resources available, but it doesn't make the answer necessarily come faster unless the idea is there. So the more ideas, the more likely we are to move forward. So the answer is definitely maybe, from what you said.
And thank you so much.
I also would like to chime in on that. So the ALS Ice Bucket money paid for me when I was a researcher in John Rabbit's lab before graduate school for at least 3 years. And then the ALS Association should also be very proud, because these ASO trials, the initial founding work for that was not paid for, like the initial evidence, not paid for by the government, not paid for by industry, but was paid for by the ALS Association money. So you guys should be very proud of that work. So those drugs that are in trial, the founding stuff for that in the SOD1 case, ALS Association all the way. So.
Well, thank you. Thank you very much, Michael. Thank you to our presenters. Thank you to our moderators. Thank you for this little window into the breaking science. We will take a short break now, and we will return in about 10 minutes.
And here's actually, these are the notes. These are the photo notes.
Okay.
So that's all of Jessica.
Best
So
first.
if you see, we would have been at.
That's right, okay.
But, so on this side.
Right.
Like, this is the scary part. Like, 'cause
Right.
if they run over.
Right.
So-
I told him it starts at 5.
Oh,
so
you told Fred?
I told Fred.
Okay.
Yeah. So I said in case you're hightailing it over here. Are these off right now?
I don't know. So yeah.
You wouldn't know.
Yeah. Anyway.
I'll step over here. Hi, everyone. I think we're going to go ahead and get started, if you don't mind taking your seats. Ding, ding, ding. Thank you all. I am Audra Hines, Vice President of Care Services with the Golden West Chapter. I am so happy to be here today. I feel like I have one of the coolest jobs in the chapter, actually. I get to lead and oversee our wonderful team of care managers across our 31 California counties that we serve, as well as the state of Hawaii. And these are some amazing men and women who work every day tirelessly with our clients living with this disease and their family and caregivers. They are out in the field, they are driving, they are seeing people in clinics, they are running support groups, and we have lots of exciting opportunities, I think, coming up this next year, maybe for some different kinds of programs, and I'll be looking to my wonderful team for all of these ideas and innovative new ways of doing things for all of you across our communities. So I'm so happy to be here, and welcome to all of you to our next half of the program. So I have the privilege of introducing our next speaker, Dr. Jessica Besbris. She is a neuropalliative specialist, and she's going to talk to us about how palliative care can enhance ALS care throughout illness.
Just making sure I know how to actually use this thing. Hi, everybody. My name is Jessica Besbris. Thank you so much for having me here today. I am a neuropalliative specialist, which means I'm a neurologist who did a fellowship in palliative care, and I feel very privileged to take care of our patients in our ALS clinic and to be speaking to all of you. That is not how you advance. I feel very technologically unsavvy at the moment. But if anyone can tell me how to move on to the next slide. Huh? The big button in the center. Of this? That's what I thought I did. Oh, the big button. Got it. So the most common question that gets asked when I walk into a room is, what is it exactly that you do? So what is palliative care? This is the World Health Organization definition. Palliative care is an approach that improves the quality of life of patients and their families facing the problems associated with a serious or life-threatening illness through prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. It sounds really nice. I don't know that it says a lot or really explains exactly what we do. So to put it really simply, palliative care is a team-based approach. Doctors, social workers, chaplains, nurses, who all want to help patients live as well as they can for as long as they possibly can. So I kind of see what I do as being a traveler with my patients on their journey with their disease. So I get the privilege of meeting people hopefully early in their diagnosis and taking care of them throughout their illness. So walking along that journey, along that path, trying to help smooth out bumps in the road when we get there, and trying to navigate forks in the road and help people figure out which way to go when they reach a critical decision point in their illness. And I'll talk a little bit more about what I often do with patients at each step along the way of their illness. One thing I want to say up front, though, just to be really clear, because it's a very common point of confusion, is that palliative care is not the same thing as hospice. Hospice is comfort care when someone is at the end of their life and is no longer seeking additional disease-directed treatments. So that is something that I'm aware of, familiar with, can talk to people about, but that is not what I do. My goal is to meet people, like I said, at the beginning of their journey with an illness and hopefully take care of them for a really long, long time, for as long as I possibly get the privilege of doing so. So palliative care is recommended for all patients diagnosed with ALS. basically from the time of diagnosis, because the goal is to help you stay feeling as well as you can from the very, very beginning. So when I meet someone close to the time of their diagnosis, my first job is just to learn about them. And that's actually my favorite part of my job, because I think all doctors want to help people in the course of illness, right? That's why we're doctors. But I get the privilege of sitting with my patients for an extended period of time and learning what makes you tick. What are the things that you're really hoping for in the face of this illness, in spite of this illness? What's important to you, and how can I help you achieve that? I can also help people early on think about documents that might be helpful in the setting of any illness, like an advanced healthcare directive, where we can identify the important people in our care, family members and friends, and let them know the things that are important to us along the course of illness. A big part of my job is just providing emotional support to patients and families, and identifying and managing bothersome symptoms: pain, constipation, anxiety, depression, insomnia, secretions, trouble breathing, and really anything that comes up that's bugging you. As illness progresses, as we move forward on this journey, it's also my job to take what I've learned about my patients and try to apply that to decisions that they're facing along the course of their illness. So for example, in the setting of ALS, decisions about things that are important for nutrition or for breathing. Part of my job is to understand who an individual patient is and what's important to them, and help them make decisions that are going to accomplish the things that matter to them most. And of course, I continue to provide ongoing emotional support and address symptoms as they arise. And in later stage illness, my role is very similar. I continue to provide that same support, continue to work on any symptoms, and if necessary, if desired, if appropriate for a patient, I can assist with transitions to hospice or answer questions about hospice or other things that come up along the course of a serious illness. So I think those were all the slides that I had, because I'm not really a slide-heavy person. But all of that is just to say that we in the field of palliative care are really here to try to make every day the best day it can be for patients with ALS. And so when I sit down with a patient, I have no agenda. My question is really just, what's important to you today? And that's our starting point. And for any given day, the role of a palliative care clinician is just to try to make that day as bright, as comfortable, as happy as it can be as you move forward with your illness. So I guess I'll have a chance to answer questions later. So I get to introduce Princess, who has been an occupational therapist at Cedars since 2014 and joined the ALS clinic in 2016. She's worked in both acute rehab and outpatient settings, focusing mostly on the neuro population, and has presented on assistive technology at the state and national levels, and is here to talk to you about the benefits of smart home technology for patients with ALS.
Hello, everybody. It's good to be with you today. Like I said, or like Jessica said, I am the occupational therapist at the ALS clinic here at Cedars, and today I'm going to talk about the benefits of smart home technology and ALS. All right, just as a disclaimer, I might throw out some commercial name products out there. I don't endorse one over another, and neither does Cedars Sinai, so if I do say a name product, it is just for an example. All right, so today I'm just going to talk about what occupational therapy is, because not a lot of people know what it is, and that's okay, and how our field can assist with the ALS population. And then I'm going to discuss the benefits of assistive technology, or more specifically, smart home technology, so that someone with ALS can maybe actively participate in their everyday tasks a little bit better. Big button, okay. So the role of occupational therapy, what is it? In the most simplistic definition, it is helping people give the skills they need for their everyday life. And depending on what setting you work in, that could be very different. So in the ALS clinic, I focus on 3 different things: ADLs, splinting, and functional exercise for the arms and hands. I'm just going to move on to the second 2 very quickly because I'm going to focus mostly on ADLs. Splinting, as your muscle strength changes, as your muscle tone changes, a lot of people might have difficulties with maintaining their range of motion. A lot of joints will get tight, and so a splint would generally be to help prevent any contractures. Functional exercise. Jessica, our physical therapist, does an amazing job with educating people with appropriate exercise. But since OTs, we like to focus on the arms and hands. So that's I would throw in my 2 cents for range of motion, stretching, and maybe fine motor exercises. Okay, so now let's get to the bulk of what I do. I help people participate in ADLs as much as possible. What's an ADL? It's an activity of daily living. I'm gonna, hold on, maybe go into this next slide. It's your basic everyday tasks: eating, brushing your teeth, taking a shower, getting dressed, getting on and off the toilet, in and out of the shower, as well as controlling your home environment. Can you turn on and off the lights? Can you control your television? Anything that you do on a daily basis, I like to help out with. Let me see if I could go back. Okay. And with that, again, as your muscle strength changes and as your balance changes, we might have to do things in an adaptive way. So maybe bringing in a type of durable medical equipment. So that would be your shower chair, your commode, some grab bars, anything like that. I like to help out with. And more recently, what OTs are kind of delving into is using smart home technology. Okay, so smart home technology, you don't have to read this. I'm going to tell you, what is smart home technology? It's anything that enables home automation. Your Amazon Alexa, your Ring doorbell, anything like that is smart home technology. So what I wanted to point out here is what year, 2020, there's 49.4 million people in the US using some sort of smart home technology, and it's projected by 2023 that 70.5 million people will be using smart home technology. So in other words, it's not going anywhere, it's getting bigger, it's getting more popular, and it is going to be in most of our homes at some point. So what OTs are doing is we're capitalizing on that and using that to our advantage for our patients. Some common smart home recommendations. I also work at the neuro clinic here at Cedars, the outpatient neuro clinic. So between the ALS clinic and the neuro clinic, these are some common recommendations that I've provided and that people have given me good feedback on. So let's say you do come to clinic and say, oh, Princess, I want to be able to control the lighting in my house. So I'll do an assistive technology screen, meaning I want to see what is the best way you can successfully achieve this task. So thankfully, something like an Amazon Alexa has 2 features. One is voice activation, and one is the use of a tablet or a smartphone. So if it's hard for you to use your voice, but you have hand function, we'll go ahead and try to get you using your iPad or your smartphone. Conversely, if you have your voice is okay, but limited hand function, then we'll say, okay, let's do this with voice activation. If both are affected, this is where I would collaborate with a speech therapist. If there's any eye gaze technologies that you're using, then I will look for products that are compatible with whatever eye gaze technology you're using. And then once in a while, I'll ask Jessica, our physical therapist, if there's any lower body function that we can use adaptive switches with. So lots of problem solving going on. Okay, so this, I'm gonna show a video in a second. His name is Mark. He has limited function of his hands, so he's going to demonstrate how he uses voice activation to control parts of his house. And hopefully, how do we?
Brief demonstration on some of the benefits of voice-activated technology. And I will be using the Amazon Fire Cube, which is the small black box in front of the TV. First, to control your lighting, Alexa, turn on lamp. Alexa, turn off lamp. You're also able to control the air conditioner and heater, which is very nice. Alexa, change thermostat to 64.
The heat's set to 64.
And finally, I'll show you a brief example of how to navigate the TV itself. Alexa, turn on TV. And when it comes on, it should take you to a home page where you'll see a number of apps, including YouTube, Prime Video, Netflix. So we'll just show you the Netflix. Alexa, open Netflix. So with your voice, you're able to navigate that app and scroll through movies and TV shows. If you wanted to watch Patriot games, Alexa, select. It will open it up. You just select either resume or play. Now, Alexa, go to channel 300 on cable. So I'm taking you to ESPN. There's a basketball game on. And from here you can control what channel you want to go to as well as the volume. So I hope this has been helpful.
And then here is Mark using voice activation to navigate his computer.
Hi, my name is Mark and I'm going to provide a brief demonstration on the use of LipSurf, which is a Google Chrome extension, and you can download it for free from the Google Chrome Web Store. Once I have somebody turn on the computer and open up Google Chrome, all they need to do is activate the LipSurf, and from that point I'm free to roam the internet. Open new tab. Search Super Bowl news. Zoom in. Zoom in. Click Joe Montana guarantees. Scroll down. Scroll down. Scroll down. Turn off. As you can see, with very simple commands, you are able to navigate all of the articles on the internet.
And then this next video is a lovely man named David. He is an attorney by trade, and he's currently teaching an online class. So here's a demo of him using something called an air mouse to navigate his emails, to grade papers. So this is the type of assistive switch that we might play around with, if not in the ALS clinic, in the neuro clinic when you come out, or if you come out to see me. And that's his iPad that he's using. All right, so is smart home technology beneficial for everyone? No, it's not. A lot of people don't even have interest in technology, and that's completely okay. We can problem solve however you'd like. But it is beneficial for the right people. Some factors to consider is the cost effectiveness of it. I mean, medical care is going to be very expensive, so I'm not going to recommend the most expensive, most extravagant types of devices, but if you have specific goals that you'd like to work on, I'm there to help research with you, because there are new advancements, it seems like, on a weekly basis. So I'm learning along with you. And if you don't come to the ALS clinic here at Cedars, I would really encourage you to maybe talk to your OTs at your other clinics to see if you can problem solve together to achieve whatever goals you'd like to achieve. All right, so these are my references. Thank you so much for your time. I'd like to now present Jessica. Jessica is a board-certified neurological physical therapist working at Cedars Sinai since 2016. In addition to her full-time role in the outpatient neurological rehab clinic, she joined the ALS team 3 years ago. Thank you.
Thank you, Princess. Hi, everyone. I'm Jessica. Really happy to be with you all today. So a question that I commonly get in clinic from patients and family members are wheelchair related. So they'll ask me, when should I start using a wheelchair? And then that's typically followed by, what type of wheelchairs are out there? And then the most important question, is it covered by insurance? So today's presentation, I'm just gonna give a general kind of overview of the most common wheelchairs for this patient population and some indications for them. So just a picture of what we're gonna go over today: transport wheelchairs, travel power wheelchairs, custom chairs, some insurance guidelines, and then the process to get a custom chair. And so just as a disclaimer as well, the pictures of wheelchairs that I have in my presentation is just as an example, but as you can see, and as I look around the room today, there are so many different types and kinds of chairs. So first I'm gonna go over transport wheelchairs and travel power chairs. So the goals of these chairs are for you to conserve your energy and prevent falls. So some signs that may tell you it's time to start looking at these types of chairs is if you're having trouble walking long distances, whether that be because of fatigue, you're getting tired too easily, or if you're having trouble, navigating uneven surfaces, or just impaired balance. And then if a walker, cane, or your AFO foot brace isn't providing enough support or safety for you anymore. And some examples of places that you may use this for is if you want to go to a mall, museum, sporting events, parks, or medical appointments if you come to somewhere like Cedars, which is ginormous, and you have to walk a little bit to get to your appointment. So this is your most basic type of wheelchair. It's called a transport wheelchair or a companion chair. They easily fold down. You can put them into your trunk or your car. They range from about like $150-ish. And the lightest weight is gonna be 19 pounds to 23 pounds. So pretty lightweight, easy to get in and out. So these next ones, travel power wheelchairs, these are the same function as your transport chairs. But if you or your loved one want a little bit more independence with being able to move yourself around, this is a good option for you. So this particular one is nice because it'll break down into 5 separate parts, so you can still transport it easily. And the the heaviest piece when you break it down is about 36 pounds. Okay, so not a little bit heavier than the other one, but manageable. And then these ones run from like $1,500 and up, depending on what kind you get. And then this is just a different kind of travel chair also. They're foldable. These ones are a bit heavier, so these ones are around 50 pounds, so harder to get in and out of cars, but still foldable, transportable, so some patients like this option as well. And these ones are usually around like $2,000 to $3,000, around there. So some pros and cons of these types of wheelchairs. Pros, like I said, they're easily transportable, they're foldable, or you can disassemble them, and they're lightweight. Some cons to them is they don't have enough postural support. So if you find that your postural muscles are weakening, or if you have weak neck muscles and your head is dropping and you have some spine curvature, it's not going to give you enough support there. Or if you're really tall, then it's going to be an uncomfortable seating system for you as well. They're typically joystick control only, so if you or your loved one have some fine motor issues or hand weakness, then it may not be beneficial for you. And there's typically no or limited seat cushion, so it's really only made for short-term use. It's not made to sit in for long periods of time because it'll be uncomfortable and can contribute to skin breakdown or pressure sores, which we want to avoid. So moving forward to the custom powered wheelchairs or manual wheelchairs. So the biggest goals for these chairs are to promote independence, conserve energy, prevent falls, provide good postural support so you're nice and upright, and then prevent any type of skin breakdown or pressure sores. Some signs that it might be time for you to start looking into one of these, and of course your physical therapist will help you decide as well. If you are unsafe walking, if you're a household ambulator only, you're having more trouble with transfers, so getting in and out of chairs and in and out of bed, you need more assistance with that. If you're falling frequently, and if you have really poor endurance. So again, this is just one of many, many kinds of chairs, and yours will probably be customized to you, so it may not look like this, but just want to give you like a general skeleton of what it will look like. So the picture on the right is just showing that the legs go up and down, so they're elevating leg rests. The picture on the left is a tilt feature, and then on the right side is a recline feature. So I'm just kind of showing you guys all the power functions of the chair. And then the picture on the right is a seat elevator. So this particular feature is not typically covered by insurance, but with the Gleason Grant and Gleason Foundation, patients have been getting funding for this one. And then if that time comes, then the wheelchair vendor and myself can kind of help you through that process. All right, so going into pros and cons of custom power wheelchairs, so electric wheelchairs. Like I said, it optimizes independence. It allows you to drive yourself, but also it helps you if you are uncomfortable in sitting in one place for so long, you don't have to ask someone else to adjust you. You can just turn on your chair, and then you can tilt, recline, and move yourself so that you are comfortable. It prevents skin breakdown, so with the customized from head to toe, you get a specific head cushion, headrest, backrest, seat cushion, so on and so forth, so that you can sit in this chair for several hours throughout the day and prevent any type of pressure sores and things like that. Another pro is adaptive drive controls. So earlier I mentioned with the joystick on those travel power chairs, not everyone in this population will have that fine motor skill or dexterity to use a joystick. So with these power chairs, with the wheelchair vendor, they can see where you have good motor control still, so that you can still operate your chair independently, whether that mean just changing the joystick to a mushroom handle, a goalpost, moving it to foot control, head control, and just recently they came out with eye gaze, so that's still in the new phase. They have a small turning radius. The smallest turning radius is 20.5 inches, so these are meant to be able to navigate inside your home, so you can get to your bedroom, to your kitchen, and all that on your own. And a really nice thing about this is because as you change through this diagnosis, you may need new updates to your chair as time goes on. And so we can always continually modify your chair as needed, so that we make sure that you're comfortable and you stay as independent for as long as possible. The cons to this chair is because it's such a big piece of equipment, it's pretty heavy, so the transportability of it is not as easy. So you would need to get a wheelchair van. If you have any steps to get into your house, you would need to get ramps installed so that you can get in and out easily. So the power chair is not for everyone. Sometimes patients just want to be comfortable but not actually control it themselves. So this is a custom manual tilt in space wheelchair that has all the functions of the power chair. It's just manual. So a family member or caregiver can help you move with those functions. And then pros and cons for this. Similar to what I said earlier about the power chairs, optimizing posture, preventing any pressure sores or skin breakdown. Everything is customized from head to toe again, and it also has continued modifications. And same thing, transportability is typically a con just because it's a bigger piece of equipment, so you're gonna need to have a wheelchair van and some ramps installed as well. All right, so insurance coverage. These are Medicare guidelines, but most private insurances follow Medicare as well, so I'm just gonna go over this. Insurances typically cover one wheelchair every 5 years, no matter if it's your standard manual wheelchair that's like $200 or the $20,000 power wheelchair. So our recommendation is to save your insurance to pay for the bigger wheelchair if that time should come. So if you need a transport wheelchair or a travel power wheelchair, what my recommendation typically is they have rental options. You can purchase it out of pocket, or you can go through the also loaner closet. So the custom wheelchair process, when to begin it, your PT will help you figure out if it's time. The 3 people involved is the doctor, the physical therapist, and the wheelchair vendor. The vendor will go to the home, do a home assessment and take measurements. And the PT will perform a wheelchair mobility evaluation, and this typically takes about a 90-day time frame. Just so that you guys know, not all physical therapists perform the wheelchair evaluation, so home health therapists don't typically do them, so you may have to go to an outpatient clinic. At Cedars, we hold the wheelchair clinic twice a month, but if you don't live close enough to here, then your physical therapist can help you find out a closer place near your home. So ultimately, the goal of wheelchair seating is to make a person as independent as possible, as safe as possible, and as comfortable as possible. And so if that time comes, if you need a chair, then between your physical therapist, the wheelchair vendor, and then also you guys are gonna work as a team to figure out what chair is best for you and for your needs at that time. And that's it, thank you.
Do we have any questions for any of our speakers? You guys did a fabulous job. Lots of wonderful information. So,
I'll come back to you.
So I have a question for the palliative care doctor. The clinic that I attend, which is UC San Francisco, I've never been informed about a palliative care doctor. And so are you, not you, but are ones available outside of the clinic sort of network?
Absolutely, and that's a really good question. Now, every geographic region is different, so there are clinic-based providers like myself. There are also, in many communities, home-based palliative care agencies that will visit a patient in the place that they're living to provide a similar service. Which palliative care agencies take which insurance is always a big question mark, and again, just depends on where you are, who's around, what insurances they take. And there are often, at least, even if there are not palliative care doctors embedded in the ALS clinic, many large centers will have a palliative care clinic separate from the ALS clinic. So at UCSF, I know there is a palliative care program. I would certainly encourage you to ask the providers there if they could refer you. But yes, there are options for palliative care outside of the setting of the ALS clinic in most places.
We have a question from the internet. Are there any special diets that you can recommend for people living with ALS?
Who would that question be for? Yeah. Do we have a dietitian speaking today? I fear we may not be the experts you are looking for, although I'm sure that our dietitian would have something to say about that. All good? Oh, cool. Thank you all.
If everyone can please take your seats, we're about to get started with the last section of today's program. Ladies and gentlemen, please take your seats. We're about to get started. Thank you, everyone. Please take your seats. We are about to start the last session of today's Ask the Experts. So for the past 2 days, across the way here at Cedars Sinai, there have been a group of individuals that make up the California ALS Research Network who have held their annual summit. And so some of our speakers today have just come from 2 marathon days of discussion, dialogue, and collaboration. And so before we bring them to the stage, I would like to invite our president and CEO, Mr. Fred Fisher, to say a few words and welcome you.
Thank you, Jenica. And I would say welcome to all of you, but you've been here for hours and hours, so I'm the one that's late to this party. As Jenica said, the ALS research community, from clinicians to biotechs to academic labs to industry partners, all of the key players in ALS research have been right next door for 2 days. And I know you've been here listening to speaker after speaker after speaker, and so have they, for 2 days straight. Every 10 to 15 minutes, a new topic, a new theme, a new conversation. And this is the 10th annual California ALS Research Summit. Back in 2007, a person named Jim Barber was living with ALS. He worked with us to pass 2 pieces of legislation that have anchored everything the Golden West chapter has been doing and has inspired our pursuit. It's inspired our growth, and it certainly inspires our focus. And that is drive the best patient care possible, establish multidisciplinary clinics and centers of excellence for ALS, and provide that model of care that is proven to help people live longer and better with ALS. And not coincidentally, but it's these centers of excellence where every single clinical trial goes. So if there is something to be tested on people living with ALS, it's getting tested in a certified treatment center just like this one. It was in 2007 when we celebrated the launch of the Cedars Sinai Certified Treatment Center of Excellence for ALS. And we really appreciate one of the speakers that you're going to hear from today, Bob Balow, who is the lead for that center and is an extraordinary leader both in the clinical space and in the scientific space, as you'll hear. And everything the Golden West chapter does is in pursuit of treatments and cures for people living with this disease. The people who are diagnosed with it, the caregivers, the family members, everyone. And our job is to find treatments and cures. And it's our outreach programs, our care programs, our clinic partnerships, and our research partners that all, in working in a seamlessly integrated way, are what's necessary actually to find those treatments and cures. You can't run a clinical trial without 3 things: great science, a great clinic to run those trials, and of course, people with ALS to participate in those trials. And the Golden West chapter is committed to advancing all 3 of those elements in a seamlessly integrated way so that we can accelerate discovery of effective treatments and cures. And it's your help, your participation here, your participation in the Walk to Defeat ALS, in all of the activities we do, that drives that effort, that fuels that effort, that makes this possible. It's all of us working together that's going to achieve our ultimate mission and vision to create a world without ALS. And after 2 days next door, I am more confident than ever that we are closer than ever, and we have the right people doing the right jobs. The California ALS Research Summit attracts the top people in the world. And we have a few of them here for you today. So without any more talk from me, let me tell you who's here to talk to you. You'll first be hearing from Clive Svensson. Clive is the director of the Board of Governors Regenerative Medicine Institute at Cedars Sinai. He's currently working closely with neurosurgeons, neurologists, and other scientists to develop novel ways of using stem cells modified to release powerful growth factors to treat patients with neurological diseases such as ALS, Huntington's, Alzheimer's, and Parkinson's. After Clive, you'll be hearing from, Clive is also the chair of the California ALS Research Summit. So that summit is a forum for researchers, planned by researchers, and Clive is the lead researcher driving our annual summit program. After Clive, you're going to be hearing from Dr. Robert Balow. Bob is a prolific research scientist who's published groundbreaking discoveries in genetics and molecular biology. In addition to being the director of the ALS program and neuromuscular medicine at Cedars Sinai, he's the vice chair of research for the Department of Neurology and director of the Center for Neuroscience and Medicine, and holds the Ben Winters Chair in Regenerative Medicine. I'm sure he won't have time today to explain what all that means, but I guess it's a good thing. It's a nice chair, a comfortable chair, would you say, Bob? It's a miniature chair. And then finally today, you'll be hearing from really another extraordinary leader in clinical care and advancing science, Merit Sukovich, who is the director of the Healy Center for ALS and chief of neurology at Massachusetts General Hospital, and is co-founder and longtime co-director of the Northeast ALS Consortium. She's been a pioneer in ALS clinical trials and therapy development. So you have hung in there, and now you get the icing on the cake. So without further ado, please welcome Dr. Clive Svensson.
Thank you, Fred. I am the icing on the cake. I feel like the real icing is coming after me with Bob and Merit. What I'm going to do is tell you just a very brief overview, 5 minutes of what we've just been doing. In fact, I had some slides put together for me, and I don't even know what they are. So I'm going to, shall I hit down, or is that? Oh, I've got the thing here, that's right. It's a summary really about the meeting, the slides. It's just going to go through the schedule that we had, and I'm going to tell you some of the highlights. This is a unique meeting. First, it's sponsored by the ALS Association in order to bring people together in this field, not just scientists. So the meetings around the world are usually it's a science meeting, or it's a clinical meeting, or it's an industry meeting, or a patient advocacy meeting. This is kind of unique in that we do all of those at once. And when I started, suggested this almost 10 years ago now, there was called a clinical meeting called PAC 10, and I said, why don't we get the scientists and the clinicians in the same room? And everybody's like, no, we'll divide up the sessions. We'll do clinical here, and then we'll do science, and maybe we'll have an industry. I said, no, let's just all sit together. We'll learn from each other. And over the last 2 days, the clinicians have been sitting in the same scientific sessions as the scientists, and the scientists have had to listen about how you design a clinical trial. And I think that's been very valuable and very powerful. And that's really the goal about this summit. Boy, that's a good-looking group of people right there. Except for the guy in the front there on the right-hand side, Fred. Sorry, Fred. This is all the mission. We know all about that. Oh, is this my slides? Whose are these slides, by the way? Are these mine? Jenica? Yes, they're mine? Thank you. Okay. I'm not quite sure. Oh, is that it? I thought you were going to have the schedule of the actual meeting there. Oh, this is the... okay, great. So we had a great meeting. So we started off with Merit, and she'll talk more about what she's been doing. This new platform trial. This is going to affect everybody in this room. It's a new way of doing clinical trials for ALS, and that's really exciting. I'll leave Merit to tell you about that. We then talked about TDP-43. This is a protein, TDP-43, that is associated with ALS. And every patient with ALS has an accumulation of this protein in both the brain and the spinal cord. And so we had a long discussion about this protein, and there's a lot of new insights coming about this protein, about how it works in the cells, how it grows over time in the cells, and eventually can strangle them and lead to cell death. It's a complicated area, but we had some of the world's experts in that field, including a great guy called Aaron Gittler from Stanford, who has some very new ideas about proteins that interact with TDP-43 and some new targets. And it was a theme of this meeting was every talk that we had, there'd be an industry member there or a clinician who'd add into these discussions. And I'll tell you in a moment about some very exciting work from a company called Biogen that you've probably heard of, an Ionis, which is leading to new therapeutics. So every time we had a talk that said, oh, this protein's changed in ALS, we'd have an industry partner that was already thinking, how can we change that protein? How can we interact with it in patients? And there was a clinician on the other side of the room who said, well, we could do a clinical trial perhaps in that area. And so this is the fun part of this meeting and the interesting part of this meeting. I then talked about a trial and in CIRM. Many of you heard of CIRM. It's the Californian Institute for Regenerative Medicine. You might have voted for it. It was Prop 71 13 years ago. And it was $3 billion to go to stem cell research in the state of California. And I'm very happy to say that the ALS community benefited greatly from that money. And one of the trials that Bob Baylor will tell you something about was conducted right here at Cedars Sinai. I was a sponsor of that trial, but really Bob was the clinical investigator that set it all up with the team the wonderful team that you've been interacting with here of staff at the ALS clinic at Cedars Sinai, implemented the trial. And a great colleague and friend of mine, Pat Johnson, who was a neurosurgeon, who carried out the clinical aspect of the cell transplantation. And again, very exciting. We presented the first data from that trial, and I'll let Bob fill you in on that in a few minutes. So these are like teasers for you, right? So you're really excited now, waiting for the next speakers. Biomarkers we discussed, these are very important. It turns out that ALS patients release biomarkers into their CSF and into their blood. And that's really important for people to follow. So if they give you a drug, you've got a way of seeing if something is changing. And one of them is a neurofilament. It's something that's released from your cells as they die in the spinal cord and in the brain, and it collects in the blood. And if you can have a sample of that during the course of your treatment, we can maybe tell whether or not the treatment's working. And that's really important. They're called biomarkers, and there's a lot of interesting and exciting work going on in biomarkers at the moment, and we've got a good update on that field. The updates from industry really encompasses 5 or 6 companies in each program, and they had 10 minutes each, and we heard from some very, very exciting new companies getting into the field with new drugs. You've all heard of Adeverone, you've all heard of Riluzole, and we've actually had a discussion about those 2 drugs, and yes, they have an effect on ALS, but it's not an effect as strong as we would like. And so, of course, we're trying to develop drugs which have much stronger effects than those 2, but they're the benchmarks at the moment. And there's many industries who have exciting molecules, some coming from Alzheimer's field, some coming from immunology, inflammation. We don't know which one will score yet, but we're shooting shots at the goal. And one day soon, I feel with all of these new drugs coming into this, what we call a pipeline, some of these are going to start hitting. And you know, getting patients enrolled in these trials is the most important part to understand if these drugs work. We've done enough mouse work. We've done lots of mouse work, and we all feel now it's time for better patient trials. And the drug companies that we've got engaged through the ALS Association and that come to this meeting are very excited. We then had a discussion about frontotemporal dementia. This is another disease of the brain that seems to have an association with ALS, particularly in senile North patients. We talked about different types of disease that kill motor neurons, including Kennedy's disease. We had some discussion with the Livermore laboratories. Some of you know that Livermore is the energy authority up in Livermore. They have a massive 1 mile wide campus, acre campus, that does all sorts of work. They have the largest computer in the world there. Some of it's military work, but they've decided they want to help the ALS community and use some of their supercomputers to try and help understand ALS. And so, in fact, Amy is in the back here, who gave a wonderful presentation from Livermore Labs. And that's an example of what this meeting does. It brings people in, introduces them to ALS and the challenges of this horrific disease, and then tries to get them engaged. And I think Amy's made a whole bunch of contacts here that she's going to be working with over the next year to see if we can put some of the federal resources into helping with this disease. We have the Jim Barber Award, had a dinner last night. We had 3 fantastic poster winners. They're excited. These are young. We like to encourage the young. Energy in ALS is very important. We then talked about the new CIRM trial, and those of you interested, the CIRM funding has now run out, but there's a new ballot, 2020. Many of you know there might be an election coming up. I think you've heard about it on the TV. That election in 2020 is going to have a ballot for another CIRM for more funding for stem cell research in ALS and other diseases in 2020. And so they're trying to get, they have to get almost 1 million signatures in order to get the ballot approved. And so they're working hard to get those signatures. So if any of you know that proposition, we can maybe, the ALS Association can help put you in contact to sign the ballot so that we can get that onto the ballot. And then if we vote yes, there'll be another $5.5 billion going to stem cell research in the state of California, some of that of which will come to the ALS community. So that was very exciting, and Bob Klein is promoting that whole program, and it's fantastic. And then finally we had this morning, Ben Brooks, who's really a source mark of the ALS community, famous clinician who really gave us a nice update on edaravone and riluzole. Bottom line is we need to do better. I mean, these are good drugs, and the ALS patients should take them, but we need to do better than those 2 drugs. We all know they're not stopping the disease, they're delaying it. We need to do better. And that really brought up discussions about how can we do better, and it went back into another series of fantastic talks from industry. And we also recognized some of the leaders in this area, and the last couple of points I'll make. I've got 2 minutes, thank you. I had exactly 2 minutes. How did I know I had 2 minutes left? In my brain, I'm thinking, I've got 2 minutes left. The Healy Center that Mary will talk about in a moment has a new award for outstanding work in ALS. And then this gives me an opportunity to bring up what I think is probably the most exciting part of the day, which is a new technology coming along called antisense oligonucleotides, or ASOs. And what's wonderful about this is a local company in Carlsbad. Now, this company used to be called ISIS, and for some reason they changed their name. I haven't figured out that why there. But they were called ISIS for many years, and I think they tried to negotiate that ISIS would change its name so that it wouldn't conflict with their company. That didn't go well. So they're now called Ionis. Now, Ionis has got a very deep collaboration with another huge biotech company called Biogen, that many of you may have heard. And what Ionis do is they develop molecules, special molecules, they're called antisense oligonucleotides, ASOs, that can target specific proteins in cells in motor neurons that die in ALS. And in SOD1 ALS, which is a gene we know about, for this technology to work, you have to know the genetic mutation. So you have to be a patient who has a genetic mutation. In SOD1, they now have a trial going in SOD1 that looks very promising. They showed some new data today. We think we're seeing some effects of this ASO in this small subgroup of patients. Very exciting. There's a larger trial that's ongoing now that we'll be getting reports from by the end of early next year, early 2021. Biogen presented that data today. There's another more common mutation called C9orf72, which many of you know about, which can affect up to 7% of patients with ALS, or does affect 7% of patients. And they have another trial coming up for C9orf using this ASO technology. So look out for Ionis and Biogen, fantastic new technology, just against the mutations that we know. And the final thing I'll say, well, first we had a great discussion about genetic testing in ALS, and I think the conclusion to that is you should all be educated about the implications of genetic testing. It does have an implication for you and your family, but if you want to have genetic testing, talk to your doctor, talk to your neurologist, talk to Bob Baylor, and discuss what the implications of that are, and then if you want to have it, you should be able to have it. And that was kind of the outcome of the discussion, that you're the patients that it would impact if you knew you had a mutation or you didn't. And it's good to have genetic counseling and talk to your clinicians about that. And the final session was big data. And this comes back to understanding ALS. With big data, what we're doing is one program called Answer ALS. You can look it up online on the internet. Answer ALS. It's a project that I'm involved with, Jeff Rothstein and Merit Jakovich, who's going to talk at the end of this program, where we've collected 1,000 ALS patients from across the country. Some of you may be enrolled in that trial here from Cedars. We're one of the members. And we're going to try and understand from that big data, genetics, stem cells, what causes the ALS and how is it different from each patient. And in that way, we'll subgroup patients. We'll understand how the patients are subgrouped and develop new molecular targets that we can then go in with specific drugs from Ionis. Because now we'll understand perhaps how ALS works much better. And that program now has recruited all 1,000 patients. We're starting to analyze the data, and we're very hopeful in the future that'll lead to new targets that we can use for new drug therapies for patients with ALS. So that was the end of the discussion today, and we're all very excited. So with that, I will leave you with the thought that this group of people is committed to working for you. We are here we're not here for any other reason than to understand ALS and develop new therapies and technologies. And it was an amazing collaborative feeling. And this to me is always the most important part, is to meet the patients and let them know we're doing everything we can, because everything we do is for you guys. Thank you very much.
Does anyone have questions for Dr. Svensson? We'll do a short Q&A right now.
Okay. One at the back, I think. I love giving talks where I don't know what the slides are. This really works very well, I think.
Yes. Since VA has a predominant amount of individuals, how did they participate in the conference? Veterans Administration.
The VA hospital, how does the VA hospital, in fact, I just got asked this question actually by Amy and the participation of the VA hospital. We would welcome the VA hospital to participate in this meeting. In fact, we would, after talking with Amy just now, we work closely with the DoD on a lot of projects, and there's lots of joint grant funding. So we should probably get the local VA more engaged here. And if you have any way to link to the VA, we are all ears. We would love to have more engagement from the VA, because there's a slightly higher incidence, as you know, of ALS in military personnel, which we don't really understand why, but we are definitely open. We're open to anything that can help understand ALS. Fred?
So Clive, just to add to that, at past summits, this is the 10th, we have had representatives from the VA. We currently, there are 4 ALS multidisciplinary clinics in California that are run through the VA, and at different times we've had representatives from the VA at the summit. The summit will be going up to San Francisco next year, and I suspect the VA's connection to UCSF will result in them being with us next year.
Great, that's education for me. I wasn't aware of the VA connection for this clinic, so that's great. Other questions? Oh, one at the back.
My question is, for those that have lived past the 5 years, will there be any trials that would be available for us? Because every time I go to the trials, they're looking for 14 months, 16 months, early onset. And it's like, well, what about me? I'm still kicking.
Right. I will punt that, because I'm very clever at punting questions, to either Merit or Bob, because they're both here and they're much better equipped to answer that question. But Merit, do you want to answer that question for me?
Sure, that's a great question. So
First of all, I think that this is changing. Depending on the drug, sometimes it biologically makes sense to be in a different group, but sometimes it doesn't. It's just a trial logistics. And I think what we're seeing more is something called expanded access program, where let's say you're not eligible for a trial, maybe they do have a cutoff of 3 years or so, that you can ask your physician to ask the company for expanded access. And some more companies are saying yes to that now than ever before. In an odd way, the right to try law that Trump did, no company actually wants to do that, but they're most of them are open to doing expanded access. And it's a little bit of work for your doctor, but not a lot. So at Mass General, actually, we have now 5 drugs that are available for expanded access for our patients. And it's all supported by philanthropy and from foundations, and it's something your center, maybe your center could do for you.
Didn't I answer that well? Thank you, Merit.
My question is there a site or an area where we can go to look at the results that have been completed or the trials that have been done to see what exactly the outcomes were, or if they did in fact help?
I'm going to say the Neil site, but Merit, you maybe want to expand on that a little bit.
Depends on the trial, but all companies or investigators, when you're done with the trial, you have to post the results on clinicaltrial.gov, but you have about a year. Companies have about a year, but they're required by law to put it there. So eventually it's all there. It's not the most interpretable there, so there are some websites, the foundation websites, our trial consortium website that do that, but sometimes there is a bit of a delay from the first results to getting it out. Also, almost all of them are published as papers, so there's another option to get. Sometimes they're not free downloads, but that might be something, again, that one could work with the foundations, the ALS Association, to get for people.
I mean, it's a good question, though, and I think a simpler way to get at that information would be great. I mean, because clinicaltrials.gov is okay, and papers are okay, but if you're a patient, it's slightly difficult, so that might be an innovative... I like things to come out of these meetings, so that could be something that a request that we can think about as a group. Fred's got his hand up. Do you need the bathroom, Fred?
Another update.
Oh, there you go.
This just in, we're actually working on a new information platform called ClinWiki, which is going to make data from clinical trials, both in terms of trials that are launching as well as trials that have completed, available and more accessible to everyone in language that can be easily understood by everyone, because if you read those papers, they're not so easily understood. We are also working to bring Neil's model of the Clinical Learning Research Institute, which is training. This is something that was pioneered by Merit through Neil's on the East Coast, training people exactly like you to be research ambassadors, to know how to read a research paper, know how to interpret a research paper, and be someone that can share that information with others who are interested. And we are working to bring that model to the Golden West chapter next year. So you heard it here first.
Great. How are we doing for time? Do we want another question? Oh, you have another
Yes. My question is, I recently was diagnosed with ALS, and I'm pretty much new with, on this. I would just like to know when would be the time frame for to enroll for the new research, the stem cell research, and also how many people is going to be considered for that.
So for the Answer ALS program, we are now fully enrolled, and we have 1,100 patients actually. And I don't think we're enrolling any more patients into that particular trial, but there are other ones that always are popping up. And I imagine there's going to be a follow-on from Answer ALS soon. And I think, our job is to get that information out to you as patients. So I think, unless Bob, you have anything else to add to that, or Merit? Okay.
Thank you.
Yep, thank you. It's very important, for recruitment, getting into these trials. We learn so much from these trials. It's fantastic. All right. Oh, another question here. Okay, last one maybe, and then I'll.
We're going to take one last question, and then again, if any of you have questions after today, you can always email them to asktheexperts@alsogoldenwest.org.
This may be the same answer as before. I have noticed every time I look up a trial, it has an age cutoff way younger than I am. How can I take part in a trial?
Again, Merritt can definitely answer that better than I can.
Just looking at you, I can't believe that. No, I'm just teasing you. But the only trial actually that had a low cutoff was the Brainstorm trial, and it had a cutoff of 60, and that was based on the early phase 2 data suggesting a better effect in younger people. But almost all other trials either have no cutoff or they go to 80 or 85. You know. Yeah, the Brainstorm is a stem cell. No, there's only one really. It's a Brainstorm, and it was driven by the biology, that there was a much better effect in younger people because the stem cells that come from younger people were more healthy and had a better effect. But other than that, if there's not a biological reason, there's not an age cutoff.
Yeah.
Thank you, Dr. Svensson.
Okay, I'm going to introduce Bob Baylor. So when I was recruited, my boss, Dr. Melmed, said, well, you can go ahead and recruit new people, and together with neurology, we went out to recruit people. And I said, well, what's your tip for recruiting people, Dr. Melmed? And he said, Clive, it's easy. I said, oh, what's that? He said, you've got to recruit people who are brighter than you are. I'm like, okay. So the only person I could find was Bob Baylor, and he's certainly brighter than I am. And with that, I will introduce Bob, who's just an amazing guy, and we all love Bob, and he's going to talk about stem cells and some of the trial that he and I have done. Bob.
No, it's definitely not smarter, but maybe funnier. What we're going to find out. Ooh. Gotcha. I know it's late. I'm gonna, if any of you have seen me speak before, as I have already done like twice today, I like to keep it entertaining and say funny things and keep it light, but get you as much information as possible at the same time. So I will try my hardest to do that. I'm gonna talk about stem cells. We didn't give you full titles. And I'm gonna cover what I often talk to my patients in the clinic about. And for a couple of those questions there, by the way, I encourage you guys about the trial results, everything else, talk to your doctors. It's one of their jobs. If you have specific trials, tell them, I want to know, let's talk about this one at our next visit. It's a great way to go over it, and they can hopefully kind of help with that. But I'm going to talk about how I discuss stem cells in general in ALS, and then several trials that are going on, and kind of where we're going from here. So the first thing to do, I have to do it here, perfect, is to say, what is a stem cell? And stem cells are not one thing, and it's the first thing that you have to really understand when you're trying to make it through this whole world of people telling you stem cells will do one thing or another. So a stem cell is actually any cell that can renew itself and turn into another cell type. So you can have stem cells at these early stages that can become any kind of cell, or you can have stem cells later, neural stem cells, that become different types of nervous system cells. Here's a central sort of neuron, or mesenchymal stem cells. You've all heard about those. The mesenchyme is the middle layer of an embryo, and that's the area that tends to become muscle, bone, cartilage, those kinds of things. So that's what those stem cells are really good at doing. And then you have hematopoietic mixed blood cells. These kinds over here can be isolated from an embryo. You can see that here. They're called pluripotent stem cells. Pluripotent to indicate they can become any kind of tissue. They're very, very powerful. And they can also be generated from patients. I'm not going to talk a lot about this. It's what Clive has done a ton of, but we do this quite frequently now. We can take adult cells, turn them into pluripotent stem cells, and mostly what we do, as Justin the Cheetah and others in the room, we can turn them into, say, a neuron. You can turn them into any of these cells in this area. So if you want to know what's wrong with your neuron, you can turn them into a neuron, or what's going on in your blood, you can turn them into a blood. So you can make patient-specific models of disease. Of course, ideally, we want to take these or these and see if we can use them for regenerative therapies. And there's a lot of promise for that.
But you can kind of get the idea from this slide of the complexity of doing that, because you've got to teach these cells how to become one of these very specific types, and then put it in the right spot and get it to do the right thing. And unfortunately, that's quite challenging, and that's why we need research, and that's what we'll talk about. But so, what I'll start off with is my first discussion that I have, I keep clicking this thing thinking it's going to do something, with my patients. Because that's stem cell quackery or whatever. And you're going to come across this, and we need to think about what that means. So this has been going on forever. As long as there have been diseases that there have been no effective treatments for, there are people who can tell you, hey, I can fix it. Cancer can be cured by reading this book, or by, you can cure your headaches with X-ray exposure, and then you can get cancer, and then you'll have to get this book. They didn't know that at the time. This thing apparently fixes your spine. I'm pretty sure that's, maybe. You know, it's to the point that periodically the government has even had to put out, you know, awareness things. This was during World War II, actually, saying a reputable physician does not promise a cure, demand advance payment, or advertise. I know that most of us understand this pretty instinctively, but when you're faced with having a disease that doesn't have a lot of great treatment options, and a doctor like me who's not really sure they have something that can cure you the next day, you start to look into these things. And I understand why you would. So that's a lot of times the discussion that we have. Now, let's learn a little bit more about it. This is so striking. There's actually more in California, by the way, of these types of stem cell clinics than there is any other state in the country. So we see this all the time. The Newport Beach one, this is not an advertisement, I promise. I found ones that I found concerning. This person here has the same problem as, oops, sorry, this guy sort of holding his head. These folks claim they can cure anything, orthopedic, neurologic, whatever, etc. And just, hey, wellness. This one is another example. You know, they claim they can cure MS, muscular dystrophy, and here's ALS. So read more. I always like to read more. And so they have a little part on their website as to what are they doing, because they're making claims that are quite striking, right? And what they're saying they're doing is patient-funded research, and we do not claim that these treatments will work for any listed or unlisted condition. These are concerning disclaimers. How does this operate? Why do we allow these people to exist? So it turns out it's because we can take, for example, I've had 3 ACL reconstructions, 2 from soccer and 1 from Muay Thai. I don't recommend Muay Thai. It's a kickboxing. It's terrible. I had to take pieces of my own body to put in and to repair those tendons, and we allow surgeons to do that. And that's essentially the conceptual way that these surgeons typically are operating. They say, they're going to take something out of you, I'm just going to put it in somewhere else. It's fine. I didn't do anything to it. I didn't manipulate it. It's okay. And the FDA has actually let that slide under the radar. In 2017, they did release a statement saying that they recognize that this is going on, that stem cell clinics that mislead vulnerable patients into believing that they're given safe, effective treatments in full compliance with the law are dangerously exploiting customers and putting their health at risk. They have not really gone into shutting these clinics down on a regular basis unless they do something wrong, unless they hurt somebody. And you might read about these events. And so, in fact, if you are a stem cell clinic director, generally your main goal is just not to hurt somebody. So you do things that are relatively benign, but probably have no chance of doing anything helpful. Okay, so, you know, moving away from there, I suppose I would say that, you know, you also have to consider that they might be doing something helpful, and I always am willing to listen. The biggest problem is they don't tell anybody what they're doing, and they don't communicate it, and that would be key, because we have to move forward by understanding the results of what people do, and then changing it and doing better and doing better. So that's the thing that they really, really do wrong, in addition to potentially taking advantage of patients if they know that's what they're doing. Okay, so let's go back to
this whole idea of stem cells, what do you do with them? So how do you deliver them? And you hear about all this. You can give them intravenously, intramuscularly, intrathecally, we say that. That's into the spinal fluid space. And this is where the brainstem cells have to go. And then there's intraparenchymal or nervous tissue. So these cells, they don't know exactly where to go. So if you put them into the blood, most of the time they just end up in the lung or liver or a tissue like that. It's really vascular and it's going to take up a bunch of cells. And the likelihood that they would ever get into the nervous system is actually really low. So you may have to put them intrathecally or even directly into the tissue. So I'm first going to talk about mesenchymal stem cells, then I'll get to the neural progenitor cells, and then I'll finish. And we can take questions. So we talked a little about these. They're derived from bone marrow. And as we said, what they really like to do is to make muscle or osteocytes, things that make bone, etc. And what's interesting is that if you take these cells, actually I'll go to this first, sorry. If you take these cells out, it's been found that they are actually spitting out a lot of protective neurotrophic factors. They have anti-inflammatory functions, so they suppress these inflammatory cells. They promote the growth of blood cells. So they actually just are spitting out a bunch of stuff that's doing good things. And that's the basis, conceptually, of the brainstorm trial or any mesenchymal stem cell trial. It's to put these cells into the fluid and hope that the stuff that they're spitting out is helping the neurons survive. Unfortunately, those cells don't live longer than several weeks, maybe a month, and so you have to keep putting them in for them to spit that out. So there are programs going on, as many of you know, the trial in the USA for brainstorm, in other countries, including Iran. South Korea, of course, I've had several patients go to a company called CoreStem. And CoreStem is basically doing the same thing I just mentioned. The difference between brainstorm and CoreStem or any of these other programs is the cell product. They take the mesenchymal stem cells out the bone marrow, and brainstorm treats them with a few things before they put them in. 2 minutes. I got a little sign here. Whoa. And so the point of that is that there are slight differences between the cell products, but not huge differences. So what we're going to find out from this trial is whether or not this concept works. Can we put these cells, take them out of the bone marrow, put them back into people, and figure out whether it's worth it? And I'm actually excited about this because I want to be able to tell patients, yes, you should do this, no, you shouldn't, and how much benefit you'll get, as opposed to saying, we don't know, let's go to some random clinic and try to figure it out. Okay, so in my last 2 minutes, I'll hit on the stem cell replacement astrocyte trial that Clive gave the results of at this meeting. I won't go into this whole slide, but it was a joke slide I put up years ago saying the neuron here is saying, hey, I'm not sure if my friends aren't supportive anymore, they're actually trying to kill me. And this is because we always talk about neurons, they're controlling the muscles, but there's a bunch of other cells in the nervous system, and they're really important for the function of these neurons. So astrocytes, which actually support the function of these neurons, microglia, which suppress infections, get rid of bad materials, help with healing, and all these immunotherapies you're hearing about, and maybe going into clinical trials or coming through this line. There are a bunch of things which are trying to keep the neurons alive, but there's one strategy, and that's the one that Clive really pioneered, and the one that's a stem cell transplantation therapy where they're trying to replace these astrocytes. Okay, so I'm going to go through these really quickly. In normal, here's your neuron, it's connected to the muscle, here's an astrocyte. It's hanging out, they're friends, they're doing stuff together, and then in ALS, this does not go well. They broke up, it's bad. And sorry, I'm trying to keep it light here, but something's gone wrong, and we don't know if it's this guy's fault or this guy's fault, but they aren't talking anymore. So the problem is, this one degenerates actually. Well, hey, there's internet dating sites. We can find new people. I've never made that analogy. I'm sorry. Yeah, I know it's been a long day, but you can replace these. That's the concept behind this stem cell therapy. So it's not to replace this cell, and a good question will be, well, why not? And the answer is not that it's not a better idea. Of course, eventually we want to replace these motor neurons, reconnect them to the muscle. The technology's not there yet, is the answer to that question. We're all trying to figure it out. We can't yet. So what we can do is give them a better environment. We took Clive over many, many years, took a type of fetally derived neural progenitor cells, was able to culture them. They primarily become these astrocytes when you do that process. I'm going to skip that. And we just finished a trial where we transplanted these cells into the spinal cord. So it was a surgery that had to take place, because if you put them in the blood, they just would never get them where you wanted to. And if you put them into the spinal fluid, they wouldn't wander into the spinal cord in here, which is a rat, but in here where you need them. These are the motor neurons on one side in an ALS rat model. This is where there was no graft, and this is where there was a graft, meaning the stem cells were put here, and they kept those motor neurons alive. And that's all the preclinical. Clive did this for so many years. He must be entertained watching me present this, I don't know. But, that was it. And we did this, it was an early phase trial, it was 18 patients. As you heard, it was funded by CERN. The primary thing we were trying to figure out was whether it was safe. The second thing was, could we see a difference in the survival of these motor neurons on one side, or the function in this case, because it was in the lower spine, of the leg on one side versus the other. And just to sort of finish up, the conclusions were, first of all, the treatment was safe. So we finished all 18 patients. Clive presented this for the first time yesterday to any big group, and it was very exciting. The treatment was safe, which was our primary outcome measure. There were no tumors that these things formed. They didn't cause any damage to the patients who underwent the surgery. That's not the only thing we wanted, but it's really important. There was a trend towards decreased progression on one side, which was the leg that was treated. But overall, we didn't see that they promoted the survival of these motor neurons. Because we go through the top part of the spinal cord, there was some pain associated with it, but it was relatively easily managed. That's where the pain fibers come in. And there were some small growths on the top side of the spinal cord as well, which were not problematic. What's amazing about this in a lot of ways is no one's ever done this. These stem cells survived in the spinal cord for over 2 years in one subject, and even after they went off immune suppression. Finally, the localization of the stem cells was a little high. So these are the real world outcomes of this. And several of the patients have passed away from their illness unrelated to the surgery. We're studying what happened to the grafts. We're looking at all of this, and we're figuring out where to go here. I think what I was trying to point out is this is really a positive outcome. And the reason it's a positive outcome, even though we didn't fix all the motor neurons in every patient that we transplanted them into, we looked at these patients so carefully. We measured everything about them, whether they were on immune suppression or not, what happened to the stem cells when they came out, what's going on in the motor neurons, and how do we measure this functionally. And now we know how to do the next trial. Now we know how to move forward with this type of a stem cell therapy, or should we move forward with this type of a stem cell therapy? And that's the kind of trials that we need to do, continue to do, so that we can advance this kind of idea beyond just, hey, we'll just give you cells and maybe we'll charge you and we'll see what happens. So that's that. This is my Stephen Hawking slide. Clive showed it yesterday. I'm probably like way over. Am I way over? All right, so I'm way over, sorry. So Stephen Hawking came to visit us a few years ago. He actually came to this room. He was over in the lab, and then he came and gave a talk here, and it was unbelievable. It was amazing. So during this time, Professor Hawking was listening to Clive give a talk here, and then afterwards, it's very hard, as many of you know, to generate a lot of content of speech when you are using the type of machine he had. He actually had an old school type. He didn't like eye movement control, so he used a triggering device with his cheek. So it would scan, and then he would trigger. So it took a long time. They said he's probably not going to say anything at all, but he'll listen. But at the end, they said he has a comment. And we were very excited, because we had told him all about our research, and so we waited. And he generated his question, or actually it was a comment, and he said, I'm very excited about what's going on here, but I'm not holding my breath. And I will remember, that is exactly what he said, and I will remember it for the rest of his life. He has great wit, as everyone who knew him knew. Anyhow, I'll leave it at that. I hope I got a little bit across to you about stem cells and ALS, what's going on in the world, where we're going, and I'll answer questions. Thanks.
Any questions for Dr. Balow? All right, in the back.
I apologize. This isn't really a question. It's just thank you guys for being here and talking to us. And I especially want to thank the ALS Association for being so great to my husband and I. And we just want to know we appreciate everything you guys do. Thank you.
I'll second.
progression, and some have slow progression? Or is slow progression really another disease?
Another great question, and it ties to one of the first question I had. What are the subgroups of ALS? What are all of the diseases within ALS? We have a few words for them. You've probably heard PLS and ALS and all these things, but that's kind of what we give them clinically. And we need to add more than just that. We need genetics, we need biomarkers, and we need to put all of that together. And that's how we're going to answer that question. And we're just kind of at the beginning of it. I think that, again, Answer ALS, other large scale, really, the platform trials you're going to hear about, and I'll prep you, is going to collect a whole bunch of biospecimen samples. It's going to continue to look at the data to answer that question while it's looking at clinical trial, drugs. And so I think that's one of the strengths we're about to hear about. All right, so maybe I get to, thanks. So I get to introduce Merritt. I have known Merritt since at least 2001, because I started my residency at the Mass General. And Merritt was not the chair then, but she was a huge influence on me with the other members of the ALS program there. I think you can imagine, as a young, bushy-tailed, bright-eyed, bushy bride resident that I was very influenced by both herself and Dr. Robert Brown. It's pretty much the reason I'm standing here. So it's actually a great honor for me to introduce Merritt. You heard all the things her titles and things, but she's a really great role model and mentor among all of those. So thank you. It's a pleasure to have you, Merritt.
Thank you, Clive and Fred and Bob, for inviting me. I can't claim I'm going to be either smarter than Clive or funnier than Bob, but I am really excited to be here and to really share some of the new things going on in ALS, and really to share that a lot of what we're doing is because the science has accelerated so fast that we can be much more creative and innovative in how we do trials, but also because we've heard loud and clear from our patients and the community that we need to keep speeding things up and working together. So I want to talk to you about a new initiative called the Platform Trial, which is a way to really speed up drug development in ALS. And this is an approach that wouldn't have made sense 5 years ago because there weren't enough drugs for it to make sense, but it makes perfect sense now, and there's really great buy-in from everybody that this is the way to go forward. So I want to explain a little bit about why this is the right time, what it is, how does it help, and how is it better for people with ALS. And in particular, really hopefully convince you that this type of approach saves time. It cuts the time to finding an effective treatment in half. That's huge. It saves costs by about a third, and it greatly increases the number of people with ALS who are on active treatments in the trials, which is really important. And we wouldn't be able to do any of this if it wasn't because of huge patient advocacy. Many of you in the room who have gone down to the FDA and advocated for them to be more flexible and open to these kind of ideas. So I want to thank all of you for that as well. So this is a long list, and it's probably not a comprehensive list, but I wanted to show it because this is the why now. There's a huge number of trials going on in the world in ALS, and this might be part of the reason why the person wrote that question is, how do I know which one to do? But I view this as a good problem to have, but your doctor, your neurologist and their team should really be helping you sort through these and figuring out what the best one is for you. Just for the color code, the red are drugs that are in what we call late stage, so hopefully the last trial, and are going to read out the results in 2020. So to have 5 of them is just phenomenal in ALS. The blue are drugs that have been in some trials in ALS and have some positive early trial, but positive results, but not in big studies or not enough to be definitive, but need to move forward. So that's a lot of blue. So that tells us that there's a lot of momentum. And this list is what's in trials. There's also like a huge pipeline right before this. Many of those targets we talked about for the last day and a half, but there's over 130 companies in the ALS space, and that just keeps growing. So there's this momentum, and that's driven by the science, that there's more understanding of the targets, and this seems like it's become tractable. But it does become a challenge for our patients. We hear this in the clinic of, what should I do? And we spend much more time on it, but I'd rather have that problem than what we had, maybe 5 or 6 years ago where we didn't have options. But you really need to partner with your neurology team to help figure this out. I don't think anyone thinks people should be figuring it out on their own. It's complicated, but it's exciting. So when you have that big of a pipeline, it no longer makes sense to do the traditional trial approach where you test one drug at a time. And we're learning this from the oncology world. So cancer is like ALS, 10 years ago, that they had a lot of pipeline drugs for some types of cancers, and they innovated on how to do this faster. And so we're, in a way, learning from them. So if we tested one drug at a time, and we made the assumption, which is a very conservative assumption, that 10% of drugs will work. And I actually think it's much higher than that. But assume that. Then to get to the first drug that worked, if you do it the traditional way, one drug at a time, we're going to be here 12 years, okay? It's a long time, 2,400 people in the study, and it's really just an inefficient way. If we use a platform approach, which I'm going to tell you about, it cuts that time down by 2/3. And again, if we're smarter about how we pick the drugs, we can cut this down even more. And so one of the things we're doing with the platform trial is we're picking the drugs as a community, the best scientists picking the best drugs to go forward. And it also cuts dramatically the number of people that have to be in the trials to get an answer, and most importantly, cuts the number of people on placebo by a lot. And hopefully, with the platform trial, we can keep reducing that number even more. So what is this platform trial? So as I mentioned, traditionally, one drug at a time, you build your infrastructure, you find your sites, you do your trial, and 12 months later, or however long it takes, if it's positive, you go and you get FDA approval. If it's negative, you shut down the whole thing. Often that data kind of sits with the companies that did the trial, and you don't keep learning for the field. In the platform trial, you build the infrastructure once, and you keep it going until you find the cures. You can do 3 drugs, you can do 4 drugs. The biggest one in breast cancer actually tested 14 drugs in one infrastructure, and several of those drugs are now on the market for breast cancer. And we want to do the same thing in ALS. We feel like this is the right time for this. So what does this mean for a person with ALS if they wanted to be in this type of trial? And I just want to say that this is actually happening, and we're hoping to be enrolling in around the end of March of 2020. And we've picked our first 3 drugs. So a person who wants to be in the trial will come in and they enroll in the platform trial, and you'll be randomized to any of the drugs that are currently available. So if there are 2 that are open, it'd be one of those 2. If there are 3 that are open, one of those 3, etc. And then let's say you were randomized to therapy A. You would know that that's the drug, the trial that you're randomized to. But then there's another randomization to active drug versus placebo. And the best we could do to be able to actually get a meaningful answer and know if the drug worked right now was a 3-to-1 randomization, which is still better than a lot of the current trials. So 75% of the people would be on the active drug, and a quarter would be on placebo. And the same for therapy B, therapy C. And the advantage here and how you get the cost savings and the time savings is that when you do the final analysis to see if your drug works or not, you're actually taking all the people in active, let's say active A, and you're comparing them to all the people in the placebos, the placebo from A, from B, from C. You're pooling those. And you can pool over time, which means that eventually, if you can show that the placebo group is not changing, you can make it 4-to-1 for the next drug, 5-to-1. Maybe eventually you can get rid of the placebo. But you keep learning and keep sharing that data, and that's some of the efficiency. So at the end of your time on, let's say, therapy A, a participant would have a choice to go into open label extension, and we made this a requirement for any of the companies that were working with us, that they had to provide open label extension. That means that you get the drug for real. So in this trial, for example, there is a 25% chance of getting placebo, but it's for 6 months, and then there's a 100% guarantee of getting it afterwards, and then the flip, 75% get it during the 6 months, and then continue an open label. But we also want to give people choice that if, let's say, they don't want to go into the open label extension, they want to go into another one of the arms, people can re-enroll and go into one of the other arms. So we really built this with the input from our patient advisory committee, which is made up of people from IMALS and our NEALS CRLI courses, and from industry. And we tried to make it as user-friendly as possible in a way that we still can get a meaningful answer, 6 months after we start the trial. The other thing we wanted to do in this trial is to keep learning about the illness. So as I mentioned, the traditional approach, at the end of the study, all that data belongs to the company, and maybe they'll keep studying ALS, but maybe they won't. In the platform trial, all the data belongs to kind of the community, and we can keep learning about the illness, and so we built in different fluid biomarkers and other type of biomarkers so that eventually we can learn. Let's say we have a drug that works, and we see it in the 6 months, maybe we could have predicted it by one of the fluid biomarkers at 3 months. That means we can adapt the platform trial, and then maybe the next time we're doing a shorter trial. And by doing this kind of a community and sharing that data, we can push the field forward much faster. So we're going to be doing sequencing, we're going to be measuring neurofilament, we're going to be partnering with Clive to get blood to make stem cells and kind of feed into the Answer ALS, so we can see if that approach can predict success. So this took a year from the initial idea to launch. Just for an example, in some of the other platform trials, it's taking like 3 years to get off the ground, and this is because the whole community has had buy-in, from the patients advising us to the FDA to the companies. And so, like I said, we're ready to go. We have 54 sites, several in California. We're going to use one central review process for ethics. And what that means is instead of every site, every hospital reviewing it and deciding if it's okay, we have one review. And again, that shaves off about 12 months of study startup. So that's a huge innovation. These are the 5 drugs. We picked them with a scientific committee. We told the companies, listen, to get this off the ground, we're actually going to use philanthropy to cover about half the costs. But we want to pick the best ones out there. So these are the 5. We're going to start with the first 3, and then we're going to add the 4th one about 2 months later, and the 5th one towards the end of the year. So they're all exciting drugs. They have different targets, and we heard from many of those companies the last day and a half more about their science. I just want to stress that I know sometimes the FDA doesn't get the best press. In this case, it's been a different story. They've been real partners, and again, I think because of the patient advocacy, we met with them twice, and we just received last week the approval from them to go ahead with the first 3 drugs, which again is huge. And that's what's going to allow us to be able to start enrolling in March. It's 6 months long. We'll see people every 2 months. We'll call them in between, and we're developing some new markers of that. So I just want to, in this like 10-minute super speed explanation of platform trials, say that this is an approach that really can accelerate how you develop treatments in ALS. It's new in neurology. It's not new in general, though. And I think we're going to see this not just in ALS, but we're going to see this Alzheimer's and Parkinson's. The FDA is very supportive of this, as well as, the companies are excited about it. The scientists are. Most important, the patients. You guys are. We've heard from people all over the country asking their doctors, like, why aren't you part of this site? Can you try to be part of this platform trial? And we really hope the enrollment will be fast so that we can get quick answers for everybody. This is going to be a perpetual trial. It's going to go on until we find effective treatments. We're going to be sending out lots of communications about how people can participate. We're also trying to line up the next series of companies to join us next year, so we can keep going to drugs 6, 7, and 8 until we find the effective treatments. I'm the one standing up here, but this has been a big community effort from our NEALS group, from our Science Advisory Board. The ALS Association just gave us a $3 million grant to partner with us on this, and like I said, we can't do this alone. So thank you for listening to me a little past 6.
Thank you very much for the presentation.
Oh, there, thanks.
So could you explain what the inclusion criteria are for this platform trial, and in particular, is there a cutoff depending on how long you've had the disease from diagnosis?
Sure. Yes, so there is a cutoff. So we tried to balance this between being as inclusive as we could and also being able to get an answer in 6 months with an affordable trial. So it's going to be 3 years from symptom onset and breathing more than 50%. And with those cutoffs, we need 160 people per drug. And it'll be 120 on drug, 40 on placebo, with a comparison at the end of 120 people to 120. We did look at the request of our patient advisory committee, could we make it out to 4 years, could we make it out to 5 years? And when we do those models with our statistician, the issue is the numbers go up dramatically, to 200, 250, 300 per arm, because of, people who fortunately have slow courses, you can't see in 6 months if the drug works or not. So it ends up being a balance. And that's why I mentioned before that it's not easy to do expanded access. You do need some resources to do it at the center. But I think it's really important for sites to have that for their patients, so that if you can't be in a trial like this, that there is another option for you. And I think we're going to see that growing more and more with the support of ALS Association and other groups.
Any other questions?
I was trying to make a plug for Fred to build an expanded access program in California. I don't know if that worked, but all right.
I'm ready.
Good. Thank you.
No, but thank you very much.
Thank you.
Makes my day when a researcher directly challenges me to do something super important. And the answer is always, okay. It took a lot of people to put on this event today. Join me in thanking the staff and the volunteers. And of course, you may not have gotten the sense, but I can tell you that Merritt, Clive, and Bob, these are world famous, best in class, top of the field ALS researchers, and I could not be more grateful to each of them for the time, the effort, the passion, and the sense of urgency to be in this space with us and to be working so hard on behalf of all of you. And so please join me in thanking the three of them for giving us their time today. So some quick stats in closing. 157 researchers have been next door for 2 days, sharing ideas, advancing ideas, getting new ideas to accelerate our progress. 113 of you in this audience today, and at any given time between 25 and 40 people online watching this webcast. And what we have in this room and what we had next door are the people responsible for finding treatments and cures. We are all in this together. It takes all of us in this together, and I know that together we will create a world without ALS. So thank you for coming, and thank you for your efforts, and let's keep going.